Yeah, good afternoon. Can I get a sound check?
If that's for me, it's Ken Miller from EMS, so I can hear you just fine.
Testing. I have long arms. Oh.
All right, good afternoon. The hour of 2 o'clock having arrived, it is time for me to say welcome to our County of Santa Clara Health and Hospital Committee. I am County Supervisor Joe Simidian, and this is Supervisor Otto Lee, who serves as Vice Chair of the committee. But in order to make that official, we need to turn to our clerk and ask the clerk to please call the roll.
Vice Chairperson Lee.
Good afternoon, present.
Chairperson Simidian.
Present as well. All right, both members of the committee are present and accounted for. And that takes us to item number 2, which is public comment. Public comment is that portion of our agenda set aside for comment by members of the public on non-agendized items, things that are not on our agenda, but that are properly within the jurisdiction of our committee. So I have at least one, possibly 2 cards here. I have a card from Leonard Williams for agenda item number 2, and if you would like to simply walk up to the dais there if you're in the chambers, and that mic will be available. And then I have a card as well from Richard Loftus, and when it says agenda item, it says not on, so I'm guessing that that means that this is for an item that's not on the agenda. And thank you all for getting your cards in because we have certain protocol that we follow, also from Paul Soto and also from Jessica Salins, and but with 4 folks. And then do we have folks who can hang in for just 1 minute?
Good afternoon, everybody. My name is Leonard Williams.
Mr. Williams, if you can hang on for just a second, and I want to make sure we reset your time. Hold that thought. Do we have folks online as well?
We do not.
All right, so if you're interested in commenting online, please raise your hand now so we have you in the queue. And then, Mr. Williams, let me apologize to you for interrupting you. Go right ahead, please begin.
Are we ready?
Ready. Thank you.
Williams, I am a representative of Valley Medical. I'm on the PFAT board. I'm the ambassador, and I represent all the clinics and hospitals throughout the county. I'm here to request some help for East Valley. As you know, we have the oldest clinic within the area. We've needed some awfully big upgrade out there. Nothing's been done. We did get it painted through Paul when the outside was all black. That's been done. We got the highway fixed, which I fixed, had the city fixed. But what we need is inside work, some inside painting, redoing. We know we're not going to get the new building we were promised 8 years ago, which I sat down and helped design. So what we would like to do is have somebody look at it, work with our manager out there, see what we exactly need to upgrade it for our patients and staff, because like I said, I know we're not going to get a new building within the next year. And even the floor, I hate to say it, the floor looks like somebody bled on it and then they did paint it over it to make it look good. It looks terrible. It either needs to be stripped and redone or whatever, but we really need some help out there at East Valley. And if we could get some help, we sure would appreciate it. Thank you.
Thank you for your comments, and as some of you may know, but not all, we are precluded from taking any formal action on items that are not agendized, but I do want to indicate that both the county executive as well as the chief operating officer are here to hear all that, as well as the head of our health and hospital system. So you came to the right place to share that concern, and it is duly noted, and I'm giving my best meaningful looks at the folks at the dais who are in a position to assess the concern and respond. Mr. Loftus, Richard Loftus? I think this is the right time and place for you, yes?
It is. Good afternoon. My name is Richard Loftus, and I serve as the Vice Chair of the Behavioral Health Board for the County of Santa Clara. And I'm here today to speak on an issue not on your agenda. It was not on our board's agenda either, but I appear to present the sentiments of the board on a matter of some urgency. As you know, our bylaws and statutory provisions, we are mandated to advise the Board of Supervisors on any matter that comes to our attention where we have, quote, concerns. We have some serious concerns about the potential disruption of the services provided by the behavioral health contractors in Santa Clara County. As you know, the state mandated the implementation of CalAIM a new program and payment system on July 1st of this year. The county also implemented a new computer billing system called Avatar at that same time. All the contractors were requested and required to implement both. It has not gone well. As of Friday, none of the 28 contractors have been fully paid for their work in July or August. Most of them have gotten some money, about 50%, some a little more, some a little less. 4 have gotten no money at all. The contractors were allowed to draw down about 15% of their annual payments to be used while the systems were being implemented. That money is now largely gone, or will be in a few weeks. Most of the contractors will then have no funds to pay staff, rent, etc. Our concern is what happens to the clients at that point. The Behavioral Health Services Department says it will make adjustments and try to make sure no one is left holding the bag. But as of Friday, they offered to meet individually with each of the 28 contractors to make those adjustments. Some believe that lacks a sense of urgency as to the nature of the problem. And we're not here to pass aspersions on the contractors or the Behavioral Health Services Department. We all know that there's a shortage in the workforce with regard to people who work in this area, but the cash flow problem is really especially acute with regard to the contractors who cannot hire, retain, or train their staff, and that uncertainty has caused a certain amount of anxiety to the people who are working with them. Not only that, but CalAIM has evidenced the nature that some of the programs that are currently in place are not financially viable and will be abandoned. Some of that cancellation has already begun. The Board of Health, Behavioral Health Board brings this concern to your board because we have an obligation to express to you the concerns that we have. We will continue to monitor this. We hope that you will too. Our concern, of course, is when the music stops, will they have chairs to sit in? Disruption.
Thank you. You can tell that your sound has just been muted by our clerk, but the message has been received. Thank you for being here. And before we move on, understanding that we can't respond substantively today, to whom shall I turn to say how would we like to follow up to make sure that whatever response is provided is timely? Mr. Williams.
Sure, I can say that there are many ongoing conversations happening with the contractors and the Behavioral Health Services Department. This is obviously very major state transformation, and those conversations are happening through the Behavioral Health Contractors Association as well as with each individual provider, and would be happy to provide an update to the board on the overall situation.
And when do you think that update might be forthcoming?
I think we can include that in our November behavioral health update. The payment and billing transition is the most major endeavor of the Behavioral Health Department at this juncture, given that the underlying funding and infrastructure for delivery of all of the services is going through this monumental change. And I know Sherry has some information that she may even be planning to discuss during her verbal report to HHC on this topic today, but definitely can provide a more thorough update both on good progress and challenges that the department's encountering as part of our quarterly report to the board in November.
I'll just indicate now, so Mr. Rao can be thinking about it between now and the time we get there when it will be a properly agendized item. I think November is probably not going to be satisfactory just in terms of the sense of urgency that's conveyed. So I'll be asking when we talk, Mr. Rao, on item 11, I believe it is, when your report is heard, that we talk about perhaps a report back off agenda sooner rather than later so that we know what the status is on a timely basis. Okay, thank you. So to be continued later as a properly agendized item, and with a report back if necessary to make sure we are staying on top of things in a timely way. And Mr. Soto, thank you for your patience because you are, in fact, the next person up, to be followed then by, I believe the name is Jessica Salons. Welcome.
Thank you. Paul Soto from the Horseshoe. First of all, I'd like to extend my gratitude to Elika, Erica, and Michelle of Supervisor Lee's office that was instrumental in making sure that I was able to maintain a very critical transitionary period from an eviction from a sober living environment to another sober living environment, which I'll be moving into tomorrow. And it was that office that was very critical in maintaining not only resources that was necessary, but also encouragement and hope. And if you come close, Supervisor Lee, to firing any of these people, you're gonna have to answer to me, you know. So please, they're saints as far as I'm concerned. So just thank you. I really wanted to extend my gratitude for their assistance. And the irony of it is the THU's in Willow Glen. The other thing that I'd like to talk about is the East Valley Clinic. United People Arriba and Sophie Mendoza were very critically, they were central, and Confederación de la Raza Unida were critical in establishing the clinics on the east side, because prior to that, we had nothing. Because this county and this city didn't care about Mexicans. They didn't care about Chicanos. They didn't care about the campesinos. And yet we were the ones that literally built the agricultural economy of the city that allowed it to become the tech powerhouse that it has become today. We get shiny new buildings in West San Jose. We get shiny new clinics over there. But then we have the señor come in here and have to say that about that clinic. And that's the history behind that clinic. United People Arriba, Ernestina Garcia, Sophie Mendoza, and these organizations. Because there was a lack of really just care and concern. This county and the city just did not care about the Chicanos or the campesinos on the east side. So what I am asking, no, I'm not asking for it, I'm demanding that the same kind of attention that we pay to clinics brand new clinics being built on the west side, over there at De Anza College, and that the West Valley needs a new clinic, you know, that we start paying some attention, because either you do that or get rid of your equity policy. Get rid of that tired rhetoric of that we are an equitable city, equity, inclusion, and diversity. Just can it, because it's getting old, because your actions speak louder than any of the rhetoric. And so I'm glad that I was here to hear what he had to say because of that history. I'm very connected to that history of what it is that my people had to do, and we had to fight tooth and nail just to get that. And I don't think the people in West Valley have had to fight tooth and nail to come here and get that new clinic. And so we need to really start talking about that within the context of health and healthcare and the racist policies that inform.
Jessica Salons is our fourth and I believe final speaker. Let me check with the clerk before Ms. Salons begins. One moment, please. Yes, this will be our final speaker. Welcome.
Hi, thanks. My name's Jessica. I'm on the Health Advisory Commission. I'm speaking on behalf of myself today. Last week, we met with Dr. Sarah Redmond for our COVID report, and we all seem to be on the same page with the scientific reality of COVID. The virus is still mutating. We continue to have high waves of positive cases. There are people that are still dying and becoming chronically disabled by it. Since governments the world over have seemed to decide that the emergency phase of the pandemic is over, I think it's time for us to address renewed preventative policies for the long-term situation we're in, as we do not yet have vaccine technology that prevents transmission, infection, reinfection, nor long COVID. So here are 4 immediate policy recommendations I have to reinstate. The first one is free N95 masks at public transportation stops and COVID care packages with masks and education about where we are at with COVID and long COVID sent to every home. I know maybe that's a big ask, but I think it's really crucial. We're only in year 4 of this pandemic. use the power of the health officer, which is presently Dr. Sarah Redmond, to reinstate masking in healthcare settings year-round. I know that the seasonal goes into effect November through March or April, but we know that COVID cases are high all year round. Babies can't mask. People who are seeking care should not get COVID infections while they're in the hospital. Work across government bodies to ensure all schools in Santa Clara County have updated HVAC and HEPA filters in every classroom. A study came out that showed 70% of COVID cases stemmed from children in school. We're letting our children be infected multiple times a year. They should at least have clean indoor air as a layer of prevention. Reopen a few free PCR test sites for uninsured and insured folks in the county to get free testing all year round. Rapid antigen tests, you often have to take multiple times in multiple days in a row. I know the federal government is sending out 4 free tests right now. That's not enough for the winter wave that we're in, so a free PCR test site or a couple in the county would be really helpful. COVID is a population-level crisis, and it's wanting population-level protections. Again, we're only in year 4 of this, and the virus continues to mutate. Both COVID and our climate crisis are showing we cannot continue living as we were pre-pandemic. We must fundamentally change how we relate to one another and how we move on this earth that sustains our lives. Please bring these basic preventative measures back. The money is here. We just have to find it. The will is here, wanting your guidance and leadership. Please respect the health and dignity of your constituents and of our collective futures. Thank you.
Thank you. Let me confirm with the clerk one last time that that was our final speaker.
Correct.
All right, thank you all very much. That takes us to item number 3, which is the item on our agenda where we approve the consent calendar and any changes to the committee's agenda that might be suggested. Our consent calendar today is listed as items 12 through 15, subject to change, of course. Supervisor Lee, I see you leaning forward. Is there a motion?
Yes, motion to approve the consent calendar, and I'd actually like to make a request to agendize an item for the HXC meeting in November regarding colorectal cancer screening through the Santa Clara Valley Healthcare and explore opportunities to improve the screening numbers. Thank you.
And that would be in which meeting again, sir?
The November HXC meeting.
Got it. I'm happy to support that consideration at that time or agendizing that item at that time. So we will move, we have a motion from Lee for the record to approve the consent calendar as contained in our published agenda and also to provide a topic for our agenda in November. The clerk will record and duly note. I will second and we'll call the roll. But let's make sure first that there aren't any speakers on the consent calendar.
I have no requests in chambers or online.
Thank you very much.
Vice Chairperson Lee?
Aye.
Chairperson Smidia?
Aye. All right, that passes unanimously. That takes us to item number 4, and we have a card from Mr. Soto. Mr. Soto, come on up. Absolutely. And I will just say that's always at the prerogative of the chair, just for those who are listening, so that folks don't think that that's always the way we go. Sometimes it's helpful to get comment from folks first before we take action on an item. Other times, if it's an information item, it's helpful to hear from the folks who are making the presentation so that folks know what it is they're responding to. So in this case, let's turn to Dr. Rudman for the report from the Public Health Officer relating to COVID-19.
Thank you so much, Mr. Chair, Mr. Vice Chair. It's nice to be back here joining you, and today I'll share 3 items for you. First, where we are right now with COVID and other winter respiratory viruses. Secondly, updates on access to the new COVID vaccine. And finally, at the request of Supervisor Lee, some details of the new options we have this season for prevention of RSV. So to begin, excuse me. There we go. I always start with our wastewater, which we find to be the best indicator of where we are right now with COVID, how much is out there, and how likely folks are to get exposed when they're in the community, in public, or crowded places. Right now, we have We are just above the medium-high threshold in Palo Alto and just below the medium and high threshold in our other 3 sewer sheds, San Jose, Sunnyvale, and Gilroy. So really the entirety of the county is hovering just around the edge of what we consider a high threshold, where one is quite likely to know somebody with COVID in a given moment or be exposed when they're out and about. Fortunately, that wave that we seem to have crested, always said with caveats that I don't know what this will look like next week, fortunately did not have significant impacts on our levels of hospitalization, nor a significant wave of deaths or other severe illness related to it. But as we have even with other milder surges, we did continue to see, especially our most vulnerable community members, still end up with considerable severe disease. I also this winter hope to bring you regularly reports on what our wastewater tells us about flu and RSV rates. If you remember from last year, at this time, we were already seeing a very significant wave of RSV. That's respiratory syncytial virus, a virus that to young, healthy adults usually feels like a bad cold, but to infants, older folks, and folks with immunosuppression can be life-threatening. So fortunately, this year we're seeing just the edge of a little bump back up into the beginning of RSV season compared to last year when we were in the full swing of things. Likewise, our flu season may have just begun to hit us here, but is not yet in full swing at all. Next, I'll move to remind you what Dr. Cody shared last month about the new COVID vaccine, and then some details about what's available to us here and how folks access it. So as a reminder, about a month ago now, the FDA deauthorized the prior booster, the bivalent booster, and authorized a new version that creates antibodies against the XBB.1.5 variant, which is a subvariant that is well matched to really everything circulating around Santa Clara County and most of the state and country right now. So this is both our Pfizer and Moderna mRNA vaccines now have this new alignment with what we're all being exposed to. I'll note there are no changes to the Novavax authorizations just yet. Now, what has been tricky, and I'll detail in a moment, is that during this period, we have not been able to give the prior vaccine, nor would we want to, because we know it's not the best option out there, but the new one is just reaching us as we speak. So I'll first share for insured folks, there are several ways to access the COVID vaccine, the new one, and this again is the first year where folks will access this sort of similar to the way you do your annual flu shot every year. So if you are insured, you may go to your regular doctor's office, to a community clinic, or to a retail pharmacy, and all insured folks should have low or usually no cost when accessing these vaccines. And one of the best ways to find where you can get a vaccine near you is at www.vaccines.gov. Now, I will share, I've been checking in addition to anything Mr. Lorenz has to share about our county system, the systems that serve large populations around the rest of the county are in a similar state to where we are here in the Santa Clara Valley Health System, in that supply has either just arrived or hasn't arrived yet. So for the systems where supply has just arrived, many of them are just getting up and running this week with their first vaccine appointments. That's places like Kaiser. And for places like Palo Alto Medical Foundation and Stanford, I'm hearing that as of at least this morning, the supply had not arrived yet. And so they were ready to kickstart appointments to vaccinations as soon as they had that supply in hand, likely early next week. But everyone's on hold waiting for it. And my best understanding is we've also just received our supply here in the county enterprise as well. What I'll add next is also important for uninsured or underinsured patients. There also continues to be a zero-cost way to access vaccines. Even though for insured folks, your insurance will be billed, this does not mean that uninsured folks will be billed. Uninsured folks can access vaccines depending on their age, either through the Vaccines for Children program, and you can find the sites that offer that by going to eziz.org, or through a new Bridge Access program for those 19 and older. And all of those sites are listed on vaccines.gov. And that includes not only specific federally qualified health centers, community clinics around Santa Clara in every district and every city, but also the vast majority of retail pharmacies of CVS and Walgreens Walgreens pharmacies in Santa Clara County are Bridge Access Program providers, and so folks may access free vaccine there if they're uninsured. Finally, I'll wrap up with another piece of good news for this year. So unlike last year and every year before it, we now have an option for preventing severe disease from RSV, which again can be fatal or severely life-threatening in young infants and older adults. So first, we now have a new monoclonal antibody. So instead of a vaccine like adults get, where we can get exposed to a piece of a virus and make an antibody, for infants, they can't do that, but we can now give them the antibodies to fight off the infection. This is just for infants who are born, who are less than 8 months old during RSV season in the winter, and a small subset of infants who are immunocompromised during their second RSV season. And this is not yet widely available as we're waiting for supply here, but will be available through the Vaccines for Children program, as well as major care systems throughout the county. There is also now a vaccine for pregnant people. And so that can be given for folks whose pregnancy lands them between 32 and 36 weeks as we head into RSV season. Now, again, if that opportunity gets missed, then their infants are still eligible for those monoclonal antibodies to prevent severe illness. And then finally, there's also a vaccine available for older adults 60 and up, especially for those whose medical conditions put them at serious risk for severe illness. And so folks are encouraged to talk to their doctors about that. Again, whether the supply has landed at major care systems is varying across the county right now. That's all I've brought you today. Supervisors, I'm happy to take any questions.
Thank you. Before I go to supervisors for questions, Mr. Soto, would you like to approach the mic now? Thank you.
Paul Soto from the Horseshoe. Thank you for the report. What I'm curious about is what COVID highlighted is the racial disparities in the way that COVID affects certain barrios. And we have that data, we have that information. What I don't see is it reflected in these reports. What is the county doing in order to ensure the protection of specific zip codes in this county? It's a very direct question, it's very explicit, and I think considering that it was my community in that barrio that experienced the most COVID infections and the most COVID deaths, that there should be some policy specific to that. That's number one. Number two is the abuses of Good Sam Hospital. You see, that was highlighted. When they got those vaccines, all of a sudden they started leveraging their power and their white privilege in order to get themselves vaccinated first, at the expense of everybody else. And so we saw very stark examples of how disgusting racist policies and racist ideology, not necessarily policies, but racist ideologies and privilege can be used to allow certain people's lives have value and other people's lives just really don't. They're expendable. We use them up for our hotel rooms. We use them up for our farm labor. We use them up to service our food industry, to garden. And then if they just die, we'll just get some more. There's plenty more that want to come here to do this kind of work. This is the kind of attitude. And I don't want to believe or think that my county takes that kind of position. But when the explicit policy is non-existent in these reports, then a person like me is compelled to come here and ask those questions. Thank you.
Supervisor Lee.
Yeah, thank you. So first of all, thanks so much for the presentation, Dr. Redman. Regarding the monoclone, the new...
Excuse me, Supervisor Lee, I'm going to ask that we either raise the volume or that you pull the mic closer or a little of both.
I will do that.
Thank you, sir.
Sure. So I did make an appointment Tuesday to make to get the shots, and then I was notified by text that the vaccine wasn't here yet, and I need to make another appointment. So certainly that is happening. And I also heard some news of some insurance company giving different guidances regarding whether they would cover the cost of the vaccines, and there's quite a bit of confusion out there. So I just want to know if you've heard any of that and how are we resolving some of these issues.
What I can share at this point, Supervisor, is individual instances where our best understanding we're receiving from insurance agencies and the federal government about their new programs are not playing out the way we expect. And so folks are hearing that their insurance either may not cover or the billing isn't going through correctly. Those are being forwarded to us individually, and we're investigating them. We haven't learned of any sort of systemic problem where that is expected. What we've heard of instead is glitches where putting things in the system isn't happening the way it's supposed to, and those glitches continue to get fixed in real time. So I think any of those instances, directing them to our office, and I can work closely with Public Health Pharmacy, would be helpful. And as I learn more about if that is a wider spread problem and not a problem of getting up and running, I can bring that to this body.
Yeah, thank you. So I just want to get ahead of the problem, if that's the case, because certainly there's been various estimates of how many people will be getting this vaccine, anywhere from 25 to 35% of the expected population will be getting it, and that of course could be anywhere from nationwide 80 to 120 million. All depends on who's getting it. But more importantly, I guess locally here, I just want to make sure that people don't get turned away and all told that they have to pay for the vaccine. So make it very clear. Second thing is on this chart. On the access regarding those under 18
Excuse the
years old.
interruption. I wonder if we could ask that the chart be displayed on the screen for everyone.
Yes, sir.
The page regarding the access uninsured and underinsured patients, that says less than equals to 18 years old and those over greater than or equals to 19 years old. Yep, there we go. Thank you. On there's the issue being the access for those under 18 years old through the VFC, the Vaccines for Children, with the website and the phone number, and those who are over 19 years old, access through the Bridge Access Program. This is certainly extremely important information. I'm sure that would benefit many hundreds of thousands of people. But certainly there's not even 100 people in this room. What's our way of getting these words out to people so that they know this is where they go, or is this something that's already built in onto their sign-up system so that they don't have to go through all these hoops to get the vaccines?
Excellent, thank you. So one of the things we're benefiting from this year is that the Vaccines for Children program is actually not new. This is the way that we've provided flu shots and tetanus shots and measles vaccines to uninsured and underinsured children in our county for many years. And so the county not only utilizes the types of clinics that are most likely to encounter these populations as they arrive here or experience insurance changes, but has longstanding communications with other entities that are likely to help serve those children and their families, whether that be schools, immigration support services, other settings where we may encounter children. So in addition to this being available information on our public health website, as well as something you can find should you just start to Google, COVID vaccine for uninsured kids. We are working to amplify it through our usual partnerships for VFC, as well as looking for new opportunities to, in the same way that we have used social media and other communications tools to help remind everyone, it's now not just flu shot season, but COVID shot season, helping to push exactly out how folks will access it, including this mechanism.
Are you working with the school districts and the County Board of Education as well on this?
Yes, we work routinely with the school districts.
Okay, great. Then shifting topic regarding the RSV prevention issues, the presentation talked about children up to 19 months on that specific infant prevention. Are we basically saying that children over 19 months should not get the vaccine?
Yes, so the approval by the FDA for this immunization is only approved up to 24 months and only recommended by the CDC, really up to 8 months for the vast majority of children, and only that 8 to 19-month group who are especially vulnerable. And the good reason for that is that thankfully, kids who are over 8 months or so the first time they get RSV usually do very well. It's an ugly cold. I know my own healthy kid had it when she was about 6, 7 months old, and it was a bad week, but it was not a life-threatening week. And so that's why, and my own review of the literature that supported this antibody therapy showed that really the benefit was for those really young infants who are exposed before 8 months.
Right. And then also on the other page talked about the pregnant people during the 32nd to 36 weeks. from September through January. This seems like very, very specific, and I'm sure it's going to be hard to get this word out. So I guess I don't know what's the plan of getting this word out to folks that this is something that they should be getting in addition to working with the doctors.
Yes, so we were actually fortunate that even as these data were being reviewed by the FDA and CDC, and we were expecting to see this approval and recommendation, we started to get outreach from some of our very proactive OBGYN leadership, not just in our county health system, but in other key partners to say, we're ready to go, let us know when it gets here, let us know what your recommendations are. So for folks who are engaged in prenatal care, and who fall in this window, I think there's a really nice system to help make sure that that vaccine gets included. For example, we work closely with health systems to make sure that there's an automatic alert that pops up around this time when somebody comes in for their prenatal check to say, oh, now it's time for your RSV vaccine, whereas that didn't used to be. Fortunately, though, the antibody preventive therapy gives us a second chance. So if somebody either was 36 and a half weeks in August 30th, or, just falls outside this window, just misses the opportunity to get their shot then, there's a second shot or a second opportunity to help the health of their infant after delivery with the nirsevimab.
Okay. Are we getting these messages out in social media or in language like Spanish and other languages here?
We are gearing up and have started in a slow way to push out information, especially in language, to our most vulnerable communities about overall winter virus season, everything you can do to protect yourself, including gearing up for these 3 vaccinations. I will say that given the delay most care systems have had to actually having the supply of the RSV and COVID vaccine, we haven't heavily pushed people out just yet. We don't want people to form a line where they don't have supply, but as soon as a week from now or 2, we can stop holding back.
Great. That's all I have today. Thank you very much, Dr. Redmond.
I have some questions and comments in a moment, but I understand from our clerk that we have someone who we have not yet gotten to who has raised a virtual hand online. So let me turn to the clerk and make sure that we welcome that person to the hearing.
Reminder to folks online that when the first speaker begins speaking, we'll close the queue.
And I'm sorry, Madam Clerk, I can barely hear you now. So if you'll speak right up and into the microphone, please.
Apologies. Just a reminder that our general practice is to close the queue online when the first speaker begins speaking virtually.
Thank you.
We have one hand raised from Delilah. We'll open your microphone. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Afternoon. Sarah Rudin just informed the board that the current booster has been deauthorized. So not only the original vaccine is no longer available, so is the current booster. LAUSD has dropped their COVID-19 vaccine mandate for their employees after a court hearing that didn't go in their favor. This is the same vaccine mandate that the Santa Clara County still has for the original vaccine. At a hearing with the 9th District Court for a lawsuit against the vaccine mandate, Judge Collins stated, there's a fair amount of science at this point that their ability to prevent transmission is in very limited window and it expires. And yet you're willing to accept someone who had vaccine 2 years ago, who clearly has no ability to prevent transmission. And yet today this doesn't fit Jacobson and it doesn't seem to make a lot of sense. Why does it take a lawsuit to do the right thing? Why do you have a vaccine mandate for a vaccine that no longer exists? Why can no one answer this question? If a new hire wants to comply with the vaccine mandate for the original vaccine and doesn't want to get any boosters, how can the new hire comply with the vaccine that no longer exists? We informed the board back in April that the original vaccine was no longer available and you ignored us. Sarah Cody informed the board that the original vaccine is no longer available and the board still ignores that the vaccine mandate is for a vaccine that no longer exists. Please stop discriminating against us and the vaccine mandate. Workers should not be having to work under a reasonable accommodation. New hires should not be tricked into getting a booster because the vaccine mandate that they're mandated to get doesn't exist. Can someone please answer these questions? Please stop ignoring us. Thank you.
All right, Madam Clerk, does that complete the number of folks who are online?
Correct.
Thank you. And did I understand you, Madam Clerk, to indicate that, and I have watched our board president, but in this committee we've not had quite the same custom or practice, that Madam President has closed the queue after the first speaker has started or finished?
It is, of course, the discretion of the chair, but practice at the board has been to close the queue once the first speaker begins speaking.
All right. I think as long as we're clear in each committee and in each setting what the expectation of the presiding officer is, that will be fine. And I will try to be clearer as we go through so that folks know what the expectation is. I will just say to anyone who's listening who'd like to speak, we of course want to accommodate your remarks if we can, but you can help yourself by getting your hand raised at the earliest opportunity. That way the clerk will know that you are waiting in the queue. Now, my turn to weigh in on this subject, and I'm going to look to the Chief Operating Officer as well as the County Executive when he's able to join us again, and certainly to Dr. Rudman, speak of. There you go. I want to try and keep this as simple and focused, my remarks, as I can, and I'm going to ask that we go back to the chart that Supervisor Lee asked for. I'm going to talk just about COVID, and I'm going to ask questions just about COVID. And Dr. Rudman, I feel compelled today to say this. You're going to hear some frustration in my tone. It's not directed at you. It's not directed at you. It's about the sort of where we are in the system. I've been approached by 3 different constituents in the last week who have told me that they were either unable to get the COVID vaccination, the latest booster, or that they went to what were for them remote distances, either from North County to San Jose or North County to South County, where apparently they were able to find the vaccine. And you can imagine that folks are a little frustrated that they have been exhorted to do the responsible thing as the public health community sees it, which is to get the booster if called for, only to be told you can't get the old one, the new one's not here yet, and we've exhorted you to do it, but there isn't any. And as you indicated, I understood entirely when you said we're holding off on pushing the message out until there's actually some vaccine there available for folks. If we could go to the slide before this one as well, please. So I want everybody to look at this slide with me. Then I want to go to the next slide. And then let me take a look at the next one if we could. Let us take a look at the next one. All right, going back to just COVID, thank you. Doctor, this may be clear to you and your colleagues in the public health arena. No normal human being can follow what the hell they're supposed to do right now to get a COVID vaccine. And that's the frustration you hear in my voice, which is we have been at this for 3.5 years. And people are losing faith in their system of government. I'm not talking about folks who have very different views, which we've already heard today, folks who think we should be doing more, folks who think we should actually be doing less. I'm saying when we say there is an exhortation to get the booster, and then there is no booster, and people are trying to figure out, well, where do I go and what do I do? And we've got this relatively complicated system that people are trying to figure out, do I go here, do I go there? And the answer is, you can go anywhere you want, but right now you're probably going to be out of luck. I think you can understand that there's a frustration. It makes us harder then to get people to actually do the thing we tell them we want them to do as a public agency, and it undercuts public confidence more broadly in our public health system and in our system of governance. So that's the frustration that I'm venting here today. Forgive me for that. But my question is, how can we make it easy for people to figure out where they get the current appropriate COVID booster and then make it happen? I also would like to know, is the problem at the federal, state, or local level? What's the source of the problem? Because people understandably want to know, hey, you're telling me to do something, I want to do it. I'm trying to keep myself and my family healthy. I'm trying to be a good member of the community, keep the rest of the community healthy by keeping, myself COVID-free. And then we tell them good luck with that. So I'm sorry to put the weight of the world on your shoulders, but you're the public health person, so I'm going to start with you. And then if either the CEO or the COO would like to weigh in, happy to hear from them as well. But I'm not just venting to vent here. I'm like trying to figure out, right now today, it doesn't seem to me there's a lot we can tell people. Next week, what are we supposed to tell people, and how can we help them get the vaccine that they need according to us? Ma'am.
I thank you for those comments. I think I share many of your frustrations, and I think understanding why we haven't been able to as seamlessly and beautifully roll out this latest booster as I would have liked is complex. I think that the two components I'd like to add are, first, that if I can try best to simplify where to go to get your vaccine, I will have a much easier answer in about a week, if not 2 weeks. I think that easier answer is, if you have a doctor and a way you normally pay to see your doctor, call your doctor, because most of our large care systems should be up and running by then. However, if you are uninsured, underinsured, don't have a doctor, the best places to look are these two websites that are before you right now. Vaccines.gov should have locations searchable for everyone of every insurance type, and EasyIZ should be one of the best places to go if you've got underinsured children. Now, to your second point about why the holdup, I think the only piece I'd add is it is difficult for me to understand in my role what's happening with the supply and why it has not landed. I understand some of our care partners can't even get a reasonable update from the manufacturers about when the supply will arrive. But I am heartened by the fact that not only our own enterprise health system, but also our key large service partners around the county appear ready to hit the ground running the moment that supply does arrive.
Let me ask, whose site is vaccines.gov?
I believe it's a federal site.
And if people go there, what are they going to learn about how, if they live in one of the 15 cities and towns in this county, where they can go to get the vaccine?
So we did have our public health pharmacists do a survey as recently as this morning and are looking at this about every 24 to 48 hours. What we're finding is that in nearly every jurisdiction, there is at least one retail pharmacy with an open appointment within the next 24 to 48 hours. That's a little bit more limited in some areas than others. So if CVS doesn't have an appointment, folks can check Walgreens. If Walgreens doesn't have an appointment, folks can check CVS, because there are retail pharmacies in every city and every jurisdiction that do appear to have appointments. On top of that, each of those pharmacies should, and I'll say should, be up and running with that bridge access program, so that if somebody is insured and they go to those retail pharmacies, they should be able to bill their insurance. And if they're uninsured, they should be eligible for these free vaccines. However, I don't unfortunately have authority over those programs or the ability to make sure that they're running exactly as they should. And as you mentioned, I've heard of some glitches in that system. So that's what we saw as of this morning, but I think it is a moving target as we watch the supply come in later than we had hoped.
And whose site is easyIZ.org?
I actually am not sure whether that's a federal or state site. I believe it's federal.
And why would somebody go to one site rather than the other to get what kind of information or access?
Thank you. EasyIZ is for children, and vaccines.gov is for everyone. So if I've got a one-stop shop for you, it's vaccines.gov.
Okay. And you mentioned some glitches. I think your office was kind enough to help my office. May have been others here from the county exec's office as well, with a Medicare beneficiary, I think, that could not, was told apparently incorrectly at a local pharmacy that they could not access the vaccine there, even though they had the vaccine and they had the appointment. Are these just, we hope, transitional glitches while people understand how the new rollout is supposed to work?
That is my best understanding. The federal government has shared that these retail pharmacies that are receiving support for vaccine supply are set up to bill Medicare, Medicaid, in our case Medi-Cal, as well as private insurers, and that should be fully up and running at this point. And so our best understanding of what happened in that circumstance was that it had to do with the system not being fully up and running as intended, which we believe to have been remediated.
Mr. Williams, please correct me if I misremember, because we've been over a lot of ground in the last 3.5 years. My recollection is that in the early days of the pandemic, and I'm back to 2020 now, we had difficulty getting some of the private or nonprofit providers to step up on the issue of testing. And I forget who it was in our own organization who came up with the marvelous shorthand of build it, buy it, or pool your tests. That was Dr.
Kamal.
Yeah, who I thought cut to the chase on that one. Then we discovered that we had struggles with some of these same healthcare providers in terms of actually letting folks access the vaccine. And I believe we pivoted from a, go to your provider model to a no wrong door model. Am I remembering that correctly?
Yes.
So where are we as a matter of county policy today on that same issue? Because what I hear Dr. Rudman saying, and I understand the theory, which is you got a doc, you got a provider, go to them and say, I want the vaccine. I want to know what I'm supposed to say to constituents anywhere in the county, not just mine, but the other 1.6 million people who plus 400,000 make 2 million people, or almost, when they tell me, I'm sorry, but I can't get it there, can I get it from the county? And the answer to that question should be what?
Yes, our system will certainly take everyone. We are focusing, of course, on our patients because we're not in a position where there's now a big imbalance between supply and demand. So we're not in the same situation as in 2021 where there were lots and lots of people who wanted vaccines but very limited supply. I mean, obviously at this particular moment in time, the supply hasn't reached everyone, but once people receive shipments, there's no expectation that there's going to be any issue or imbalance between overall manufacturing supply and demand.
So if someone is to ask any one of us, our offices, the proper response would probably be, it's probably best for you to go to your own healthcare provider, but if that doesn't work for you, please know that you can go to the county, and you are certainly eligible to receive the vaccine there, assuming it's available. Yes?
That's correct, but I would just want to note, I mean, one of the things that also shifted, and this is very much reflected on the vaccines.gov website, is the role of retail pharmacies. And they're everywhere. There are dozens and dozens and dozens in our county. They have ample supply. They are the prominent entities listed on vaccines.gov. They've created systems to make it easy for folks to get vaccinated. So that's, at this point, a big component of people's access to both COVID and flu vaccination.
Yeah, I think the challenge, and I'm just going to be blunt about it, the challenge is that's what people are told, and then that's not what they find in their everyday experience. And in fairness, that everyday experience changes day to day, sometimes hour to hour, and certainly week to week. So, I think we saw during the last 3.5 years that what was good advice on Monday wasn't necessarily good advice on Tuesday. But to your point, if we say, well, you've got your providers, you've got the pharmacies, and then, by the way, your county is still there for you if neither of those is your most convenient, and typically going to one of those two places, your provider or your pharmacy, would be more convenient than getting to a county site for people, fair enough. But so then the question is, where can people get the COVID vaccine booster that is now the recommended booster at a county facility. I turn now to Mr. Paul Lorenz, who is leaning in.
Thank you, Supervisor Simidian. So, in fact, we did receive our vaccine supply today as a health system. What we've done is publish for the public the locations for which individuals can receive both a flu vaccine and a COVID vaccine. The COVID vaccine will be available beginning October 2nd. The sites are listed on the county's COVID public health site, and individuals can schedule an appointment at the locations listed. And those locations are throughout the county of Santa Clara. And these locations will complement, as been stated, the other retail pharmacies and other health systems that are now making the vaccine available.
Now, that is the sheet that you handed me just as I sat down today. Is that correct?
Yes, Supervisor, that's hot off the press.
Thank you. And I'm looking at a single page, one side, and I'm just going to make sure I understand what I've got in front of me here. Location and days and times. Adults 19 years and older is the bottom roughly half of the page. And that's where people could go effective, if I'm reading the top right, October 2nd as a backup, I understand, to get a COVID shot, yes?
Yes, Supervisor.
All right. And I'm looking at 1, 2, 3, 4, 5, 6, 7 of those sites. And I'm looking at 1, 2, 3, 4, 5 of them are in San Jose. Is that correct?
Yes, Supervisor.
And one's in Sunnyvale and one's in Milpitas. So how about folks in the North County, South County, and West Valley?
Supervisor, so the section above that, which is also adults
Got it.
and children 3 years and older, there are additional locations noted.
Got it. So that's for both adults and children,
Correct.
and it's for both flu and COVID.
Yes, sir.
Okay. Thank you. That's helpful. That it may just be that I'm the only one who didn't read it that quickly and clearly, but it may be that thinking about that is helpful. So Gilroy is there for folks in the South County. Mountain View is there for folks in the North County. And there are these two other sites in San Jose, and presumably one of the now 7 sites in San Jose would be relatively convenient for folks in the West Valley, we hope, yes?
Yes, sir.
But back to you, Dr. Rudman, and to Mr. Williams, probably more likely that if they could get their provider or their pharmacy, that'll be more geographically convenient.
Yeah, I think there's no question geographical convenience is definitely going to be from one of the major retail pharmacies. They're everywhere.
Now, before we share this information, let alone, quote, push it out, I really am going to put you on the spot here, Mr. Lorenz, so thank you. How confident are we can deliver on this? Because I don't want to be giving this advice to people if we're not absolutely positively sure that we can deliver.
I'm confident we can deliver, and we will monitor the utilization, and we will make adjustments as needed.
Okay. Now, you mentioned our own public health site, so that's a third site that people can and should look to?
I believe the public health department site is accounted for here as the Valley Health Center lens in.
I'm sorry, would you say that again? I think it was just the muffle from the mask. That,
Excuse me. The second site under adults and children 3 years and older is the Valley Health Center Lenzen, and that is the travel and immunization clinic that's operated by the public health pharmacy, and that includes, that will, starting October 2nd, include COVID vaccination.
But in order to make an appointment for one of these now that I've been schooled, I guess it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 sites. You go online to do that, yes?
Yes, sir.
And where do you do that?
On the county's public health website.
It's the same site since the early days of the pandemic, covid19.sccgov.org.
COVID19.scc, one more time, please.
sccgov.org.
Right. So now, and my point here is in teasing this information out is that now we're telling people there are 3 different sites that they might go to. Particularly for some of the much older folks we're trying to reach, who are, as I understand it, among the highest priority for the booster, their technological comfortability may be a little less. I'll let it go at that. All right. And the reason the flu begins on 9/27 and COVID begins 10/2 is what, if I may ask? Just I'm going to try and stay on COVID as I promised I would, but
The availability of the vaccine. We have the flu vaccine now, and we're making it available beginning today.
all right. And there was passing reference, I think, Dr. Rudman, and it may have been in response to a question, forgive me, about schools, particularly around the kids. Could I ask you to be clear and specific about what the county public health department's role is with respect to schools? And the reason I am asking is I continue to get people who are grumpy, in some cases for things that happened 3 years ago, because they believe that our county public health department played a role in decisions that were made at their local school district. And as I listen to them, in many instances, I think that that's not a correct understanding, that it was a function of direction either from the state or by a decision by their own local school board, which had a very tough job. I don't deny that for a minute. But so when it comes to schools, who's in charge of what? Who's responsible for what? Who decides what, please? COVID-wise.
There are currently no health officer orders in effect in Santa Clara County or other sort of local requirements that would play out in schools, with the exception of nurses' offices or similar locations where healthcare is provided in a school. So everything else with respect to COVID that governs a school would be either the state school board or Cal OSHA. And I'll look to Mr. Williams to see if there's anything to add.
Yes, I can confirm that and just say, there's, throughout the pandemic, schools faced regulatory requirements from multiple sources, and there was the added layer of not just CDPH at the state level, but also the California Department of Education at the state level. Today, the requirements from the state level that are mandatory are from Cal OSHA, and those apply to all employers, including the county and schools and everybody else. They are largely related to reporting of cases and masking in the event of multiple employee cases in the same space within a certain time period.
So is it fair to say that today, if a local parent were to ask, who's making the decisions about what we have to do in our local school district, the answer would be, could be Cal OSHA, could be California Department of Public Health, could be the California Department of Education. It is most certainly your local school board and superintendent, but we have nothing presently affecting the operation of your
That's correct.
K-12 school district.
That's correct.
Okay. Now, back during what I'll call the heart of the pandemic, what, if any, were the decisions that were made by the county, meaning the county's public health department and public health director, with respect to the operations of schools? And part of the reason I ask the question is I remember the March 10th meeting. I was sitting right over there, and Dr. Cody was sitting right there, and if anything, she was communicating her strong desire that schools stay open if it was at all possible for a variety of sort of larger reasons. And yet, as I encounter folks out in the community, they think that it was our public health department and director who was the reason their school was closed. So who gave what direction to whom?
You have that right. The schools got caught in a very complicated regulatory situation, especially in the fall of 2020, when the state issued significant school-specific guidance, just as the state was doing elsewhere in issuing industry-specific guidance. You may recall the county never had a regulatory framework at the county level that was industry-specific, but the state did. And the county could not have regulations that were less restrictive than the state's. And so by necessity, those industry-specific requirements applied here in Santa Clara County as well. That meant for schools.
Excuse the interruption, Mr. Williams. It strikes me then that if we were making an effort to be helpful by explaining what was happening at the state level, that there were some folks who thought that that was a direction they were receiving from the county, perhaps not understanding that it was actually a state-level direction.
Oh, certainly so. And for schools in particular, in our Emergency Operations Center, we had an entire team that was stood up. We got wonderful staffing assistance from the Santa Clara County Office of Education, but a dedicated team that provided a lot of support to schools precisely because, as you referenced earlier, Dr. Cody was a strong proponent of trying to have schools open. And so, in fact, there was a process in the September timeframe of 2020 where a local health officer could, in essence, apply for permission from the state once you were in one of those tiers. You may remember the colored tiers. This was, again, all the state's blueprint framework. And if you were at a certain colored tier in the state's framework, then your local health officer could ask the state for permission to allow schools to open. We did so. Santa Clara County did so. Dr. Cody did so. But it was subject to then a whole package of state CDE and CDPH rules around those parameters. And the reality of the implementation of that package looked very different district to district in terms of what districts were in a position to realistically be able to actually comply with those requirements, and other districts that weren't for a variety of reasons. So there was a lot of effort at the local level to provide support to districts to try to enable that reopening, but it was very challenging regulatory environment given those state rules.
To the best of anybody's recollection, what orders did come from our Department of Public Health, our public health director, that were specifically directed at schools, if any?
We had orders that were broadly applicable that also impacted schools and school operations, but I'm not recalling any that were school-specific.
That's the same. I don't recall any that were school-specific.
Thank you. All right, I want to wrap this up. I know we've taken a lot of time on it, but I want to wrap it up with a couple of exhortations, understanding that, as County Council reminds us from time to time, that we don't have authority as a two-member committee of our board to provide formal direction to the county organization. But I will say, I hope that whatever we communicate with people will be as clear and simple as possible. If I've learned anything about public health from working with you all over these last many years and during a previous stint, it's that if you want people to do something, you need to make it easy for them to do it. And when it's not clear, or it's remote, or it's complicated, participation drops, and that shouldn't be a surprise. The second thing is, I do think the no wrong door policy is an important policy for us to be very clear about, and I don't have any problem at all encouraging people to go to their regular provider or to a pharmacy, but I think we need to be very clear that when those systems fail us, we should be on the job talking to those systems to say, hey, you have a role and a responsibility, please step up And we should be very clear that if we have to be the provider of next resort, that we are the provider of next resort when it comes to the vaccines. Because while I heard the reference to our patients, which is probably, I don't know, Mr. Lorenz, I'm going to say 400,000 out of 2 million people, more or less, but growing to maybe 600,000 over time. We are the public health service for all 2 million residents of this county, and our support for those residents needs to reflect that. Okay, thank you. I believe all we're supposed to do here today is receive the report and receive report from Public Health Officer relating to COVID-19.
So moved.
Second, call the roll, please.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Thank you very much. That takes us to item number 5. And let me just say now, for the benefit of the clerk, if you are a person in the chambers where we will go first for public comment and you would like to speak on this item, item number 5, hospital integration performance, please bring your yellow slip up ASAP so we can call on you. And if you are interested in commenting on this item virtually, then per the clerk's encouragement, I will say please get your hand raised before we call up the first speaker. Now, on this item, I think it would be helpful to get the report first and then go to public speakers. So again, if you are wanting to speak, please get your card in ASAP. And I think I turn it over to Mr. Lorenz for this report.
Thank you, Chair Simidian and Supervisor Lee and committee members. Back in March of 2019, the county acquired O'Connor Hospital and St. Louis Hospital. Since that time, we've seen the benefit of having these two hospitals as part of our integrated healthcare system. We probably over the past 4 to 5 years, it was most notably during the pandemic, in the importance of having those hospitals as part of our delivery and healthcare system. Since that time, these hospitals have grown to be of substantial benefit to the community, and the report reflects some of those benefits, primarily in the ability of the system to provide essential healthcare services. At O'Connor Hospital, there's been an impressive growth in the system, where the average daily census has grown by 62% since the acquisition, grown from an average daily census of 116 to an average daily census of 188. At St. Louis Regional Hospital, we've also seen a remarkable growth at that hospital, where the average daily census has increased by 82%, close to 83%, since the acquisition. It has an average daily census of around 53. Previous to that, it was in the mid-20s. The O'Connor Hospital Emergency Room, ED visits have rebounded significantly. Today, the ED at O'Connor Hospital at the close of 2023 had seen close to 67,000 emergency room visits. That's close to a 40% increase since the county acquired the hospital. At St. Louis Regional Hospital, we have also seen the ED visits grow to 41,000. That's a 37% increase since the county acquired St. Louis Regional Hospital. And I would note at St. Louis Hospital that just in the past year, since fiscal year 2022 to 23, there was a 14% increase in volume. So we continue to see that trend relative to the growth in both of those hospitals and the overall healthcare system. Also in the report, you'll note that we provide a summary of our market share in terms of the different payers. Since the acquisition, there has been a notable shift in the payer mix across the 3 hospitals. In the 12 months ending March of 2019, Medicare patients represented 27% of our total patient days as a health system. Today, Medicare patients represent 37% of our patient days across the 3 hospitals. That's reflective of government subsidized health insurance programs and the need for the public health care system to continue to provide access to these patients. That's a shift from other hospitals to your healthcare system of Medicare patients. And that's primarily due to the lower reimbursement that providers typically receive from these government programs. Today, the market share, just so people have this perspective, Santa Clara Valley Healthcare provides close to 40% of the Medi-Cal patient days in Santa Clara County. Exclusive of children, where Lucille Packard sees a large number of Medi-Cal patients for obvious reasons. The adult population, Santa Clara County Healthcare serves close to 50% of patient days, hospital patient days in all of Santa Clara County. So this clearly demonstrates the substantial presence and role the county plays in healthcare in our community. Over the past couple of years, the health system, as with many other healthcare systems, has experienced unprecedented increases in costs associated with labor and other goods and services, such as pharmaceutical costs. Pharmaceutical costs alone, from last year to this year, have grown 19%. This is an industry-wide challenge relative to keeping a balance between expenditures and revenue. As we all know, the revenue in terms of reimbursement for healthcare system is simply not keeping pace with the overall cost of healthcare, and we know that. So a couple things that you should know that we're focused on, and this was outlined in our business plan presented to your board. And that business plan outlined a number of different strategies to bring in balance our revenues and expenditures. So I just want to summarize these, and this is something that Vinod Sharma, our Chief Financial Officer, is very much on top of. We are looking to optimize our revenue and improving our efforts around our revenue cycle process and our receivables. We are looking to maximize our supplemental revenues, and as a public healthcare system, those supplemental revenues have grown to $750 million. So that focus is critically important as we move forward. And the other area that we're focused on is making sure that we continue to grow the number of lives our healthcare system cares for, particularly the Medi-Cal managed care lives where we received capitation revenue.
Excuse the interruption here.
Yes.
Ms. Lorenz, this is not a flip question, but I can see the clerk looking at me to follow my own direction here. So if we're looking at a $400 to $500 million deficit, investment, whatever we want to call it, it might seem counterintuitive to some that the way we improve our position is if we're losing money on all these patients, that we make it up in volume. So could you explain briefly, even though you've done it before, why more patients doesn't just mean bigger deficits?
Supervisor, so when I refer to our Medi-Cal managed care lives, those are individuals that we serve as a system for which we receive a monthly capitation payment. So we are guaranteed those revenues on a month-to-month basis, which helps us relative to our fixed costs. So the more lives we're able to have within the system, and in fact, we're able to manage them in terms of making sure they receive early and regular health care from a preventive health care, then those revenues do benefit our system.
That would be the case presuming that we didn't actually lose money on those Medi-Cal patients as compared or contrasted with the capitation payment, yes?
On the fee-for-service Medi-Cal and Medicare and the other payers, our goal is to maximize those revenues. These are individuals that have nowhere else to receive their health care, and they depend on our healthcare system to do so. So we receive, as I mentioned earlier, a large amount of supplemental revenue, and those supplemental revenues help that shortfall in those fee-for-service patient revenues.
Let me try it a different way. If we have a patient, a Medi-Cal capitated care patient, who's ours,
Yes.
are we going to end up spending more to give that person the health care that they need and deserve during the course of the year than we receive in the capitated patient payment?
So on the capitation, we net more revenue than we do have in expenditures for that patient population.
Okay. Thank you. Sorry for the interruption. Proceed.
So with that being said, I just wanted to give you some current year numbers. So relative to the fact that where we stand with regards to our supplemental funding, the other funding that we receive is our county investment. And as you noted earlier, that number of our total operating budget has grown to around 13 to 14%. Our goal is to reduce that reliance on the general fund and bring that down closer to 10 to 12%. So year to date, some numbers. Total revenue fiscal year to date through August across the entire system has been favorable over year by 8.2% in terms of our gross revenue. That's $33.6 million. So our gross revenue has improved. And revenue here is attributed to the strong growth in inpatient setting, with gross inpatient revenue across the three hospitals increasing by $28.5 million, or 8%, in August over the prior year. So our revenue cycle processes and improvements that we've undertaken is helping to not only improve our gross revenue, but our net operating revenue. So I wanted to share that with you because this is an indication that we're moving in the right direction, and we're seeking to close that gap relative to revenue and expenditures. We're not quite there yet, but this is the type of effort that we need to undertake in order to create a financially and sustainable health system. So with that being said, Supervisor, I'm happy to take any questions.
Thanks. Let's see if we have any speakers. I don't have any cards up here. Do we have any cards from within the chambers?
No cards in the chambers and no hands up online.
All right, then last call, just to make sure there's nobody online or nobody who waited here in the chambers. Still nothing, Madam Clerk?
Nope.
All right, then we will close public comment. There is none today on this item, and I'll turn to Supervisor Otto Lee. Supervisor?
Yeah, thank you so much for the report here. First, I just want to correct the numbers. You mentioned revenue 33.6 billion. You mean 3.36 billion, right?
33 million.
Oh, no, I'm sorry. There's a good point. Okay, because I'm just making sure I'm looking at the right thing. I'm looking at total revenue.
Apologies,
total
Supervisor. I'm
expense.
having trouble hearing you.
So make sure I'm reading the right places here on where we're talking about. So let me say, going back to page 8 of 15.
Supervisor, I want to make sure that we record every word. Let me rearrange you.
My arrangement, yeah. Thank you so much.
Appreciate it.
Okay, this is better now. Okay, thank you so much. So just making sure I'm getting the total picture. So on the trend of financial performance on page 8 of 15, actual total revenue on 23-24 from prior years, we're looking at the actual revenue is 2.87 billion. This year, we're budgeting for 2.88 billion.
Okay.
Obviously, we don't know what the actual is until the end of the fiscal year, but of course, at the end of the day, we're looking at the bottom line of what the total surplus versus deficit. In this case, last year's deficit has now ballooned to 444 million, right? Am I reading this correctly?
That's correct. So Supervisor, going from fiscal year 22, 21-22 to 22 to 23, it grows to 13.4% from 8%
Right.
in that prior year.
Right. So I'm just looking at the trend, and the budget says that we're estimating that we'll have a deficit of even greater to 475. Yeah, right, correct. The 475 million here. So basically, the trend here is that our deficit actually is going to be growing based on the current estimate, right?
So Supervisor, you're correct. From fiscal year 2023 to the current year budget, we're budgeted at 475 million in county contribution, which represents 14%. So that's the budget. Obviously, depending on our performance for the rest of the year, that number will change.
Right, correct. But at least what we're estimating is that it's not getting better. We're actually expecting to get worse. I think that's the
And
gist of what
Supervisor,
I'm getting, right? Yeah, exactly. And so you mentioned because of the cost is certainly increasing, that's why we're having a higher deficit. For the 21-22 years, we had some funds, the federal funds, but there's more like a one-time thing, and that's why it's helping. And you mentioned that there are some of these supplemental revenue that we can maximize. Could you go into a little bit more into what those are and how else can we come up some more ways of finding revenues for our system?
If I can just kind of maybe say a bigger picture comment, what you'll see from the table is year over year, you'll see revenues growing, and you'll see year over year operating expenses growing, but growing in the last few years at a faster clip, right? And so, there are a few different factors and issues, but one of the biggest ones is that we have had some significant cost increases associated with personnel costs, quite significant, and those cost increases then take some time for them to hopefully be reflected in revenue cost recovery as rates get adjusted. So there's a couple different things going on. There's the COVID issue that you mentioned. That's definitely a factor. There's the labor cost increases and the fact that it takes time for those to catch up. That's a factor. There's the supplemental revenues that you're talking about, and that's a factor. And then there's, needs to identify other ways to increase revenue. And there's a number of projects underway related to that as well, including looking at the revenue cycle. So, Paul, you can add to that, but I wanted to take a little bit of a step back before we just dive into the supplementals, which, of course, are important. And there's other issues associated with supplementals, including the fact that we have timing challenges on the receipt of most of those. They tend to run 12 to 18 months after the close of the fiscal year because of how they're calculated before we receive them. So there's a lot of different kind of facets to unpack there, but I wanted to take a step back and just to make that bigger picture observation, and that one of the biggest drivers here is definitely the very significant personnel cost increases in the last couple of years.
Thank you, James, or Mr. Williams. So just to answer your question, what are the things we're working on and focused on to improve our revenue picture? One is, as I mentioned, our revenue cycle process. And as noted, there's been, in fact, Vinod Sharma is here to speak to that. In the first 2 months, we've seen an improvement in that area. The other area that we're also focused on is our supplemental revenues. And let me give you an example of our supplemental revenues. It's called Quality Improvement Program. It's a program through the state in which we draw down federal dollars. And that program focuses on our ability to improve the quality of care in our system. And that program represents around $160 million. And it's based on our performance relative to those quality metrics. So obviously, being prudent, we don't budget 100% of those revenues because it's going to depend on how we perform throughout the year. But if we are in fact able to reach 100% performance, that's going to generate 100% of those revenues. So the healthcare system, we are focused on improving our ability to maximize those revenues through quality programs to make sure that we achieve those metrics. So that's both an operational imperative, but it's also a financial focus of a healthcare system to make sure that we have a large enough pool that we can benefit from. So those are examples of things that we're focused on as a healthcare system. Vinod Sharma, our CFO, is here. He can also supplement that, but at this point in time, I think we can take further questions from you.
Now, can you hear me?
Much better.
Better, thank you.
Good afternoon. Vinod Sharma, CFO for the Health and Hospital System. We have done 3 different measures, basically. First is the revenue cycle improvements. That's aimed at using technology wherever possible, automating processes and best practices. And the goal is there to reduce the denials and timely billing and also make sure what we are expecting versus what we are getting payments, that bridge is narrowed to 0 almost. That system is expected to grow. Our fee-for-service revenues, which are going through the revenue cycle, is about $120 to $125 million a month. That's about $1.4 billion a year, and that's expected to grow by 6 to 8% in a year. That's about $100 to $120 million a year growth as a result of these measures that we are taking. Some of these have already started working, and others we are in the process of improving the technology and implementing the technology, and those results will come. As far as the fee-for-service revenue is concerned, as Paul mentioned, that compared to last year, year over year, it's about 8% or 8.2% growth. And out of that, about 3% is due to the volume increases. And the remaining 5 or 4.5% is primarily due to the efforts that we are taking. And as the time passes, we would see better improvements. But more of the improvements will come in the later months as some of the best practices and technologies are implemented. So that's for the fee-for-service. On the capitation revenue, which is about $400 million, we are also working on the Medicare redetermination project, which is item number 8 in this report, where we are making effort to go out and help people retain their Medicare coverage. Up till now, we have helped about 10,000 people retain it, and another 6,000 are in progress. That is another big chunk of revenues. Together, they are about $1.6, $1.7 billion of fee-for-service and capitation revenues. Supplementals are another $750 million. It's plus and minus a little bit. That is also expected to grow as our managed care members and the population is going to increase. There would be some impact on the supplemental revenues, but that may take a little time, and we are working with CAPH to make sure we have better handle over those.
No, thank you very much. I think this is helpful to kind of get a little bit understand. So for the quality improvement program, Paul mentioned 160 million will be the ideal, but you also mentioned 750 million. Maybe you could help me understand the differences we're talking about here.
Yeah, 750 includes other programs too. QIP is one of them, and there are 40 matrices we are trying to work on to make sure we achieve them, and then basically that optimizes or improves our revenues there. Then there is EPP, Enhanced Payment Program, and GPP, Global Payment Program. Together, these three programs bring in about 600 million, then few other supplementals that add up to 750 to 800 million dollars.
Okay, so trying to understand the mechanics of these. When you say quality improvement, is it based on the fact that certain programs that we have exist and we get additional revenue from reimbursement from the feds, or is it because of the fact that our work is so good that through these surveys and getting good scores that we're being awarded these additional revenue? How does that work?
There is a, go ahead, sorry.
So the quality improvement program is focused on those preventive health measures that, as a healthcare system, would look to improve upon in order to save money. So if we're saving money through the fact that we're getting people in for the preventive health screening, such as mammography, then the system will save money because we're going to identify it early and provide treatment. So that's the focus of a quality improvement program relative to our Medi-Cal population. And so when you have 40 to 50 metrics that we're following and that we're trying to improve upon, then you could have substantial improvement in not only the quality of care, but clearly the financial outlook relative to the cost of care.
No, I get that, we would benefit from people doing early screening and prevention. I completely agree. I guess what I'm not getting is if less people are getting breast cancer due to the fact that we have better screening, it's good for the community, it's good in overall. How does that increase our revenue, though? I mean, it will decrease our cost, seems like, but how does it increase our revenue? That's what I'm getting at.
So let me explain. So there's $160 million that we are eligible to draw down. If we achieve 100% of those metrics, we will draw down $160 million. If we only achieve 80% of those metrics, then we're going to get far less than the 160. We could only get $140 million. So our goal is to make sure that we achieve 100% of those metrics, so we draw down the full amount of dollars that are available to our health system.
With Supervisor Lee's patient concurrence, I'll just lean in and say, Ms. Lorenz, this is a difference between healthcare 25 years ago and healthcare today. It used to all be about fee-for-service. There were limitations to that model. In theory, we are making a transition to being rewarded for keeping people healthy in terms of the incentive structure available today. Is that a fair recapitulation?
Yes, it is.
And, you know, in theory, it's a good thing to behold, but the day-to-day practice of it. Thank you.
Okay, thank you. So these the 160 million will be coming. Is that from federal or is that from state? Where does this money come from?
It is federal dollars that are drawn down through state Medicaid program.
Right. So my understanding would be, correct me if I'm wrong, I'm still learning here, is that by having these very good metrics, we could show the federal government, say, hey, see, look, we have all these preventive care, very few people are getting sick, and because of that, give us that money. That's basically how this works?
Yes, we've earned the money based on the program requirements.
Great, thank you. So that, assuming we're 100%, we get all that, right? So there's no more to get out of it. Obviously, if it's 100% is the best we can accomplish. On the budget that we provided, that shows that we have a larger deficit. You did not budget the whole 100% on it, right? We're budgeting something less, but it's likely that we get a better outcome. That deficit would therefore be smaller, correct?
Yes, so it will help our bottom line. You're correct. We do not budget 100% of it. That's the prudent way to budget. because every year, those metrics, in terms of the marked improvement we have to achieve, is increased.
Right.
So we have to step it up year after year.
Right.
And so if we're able to meet those metrics through the team's effort, the clinical team's effort, then it is net more revenue to the system.
Okay. Now, in terms of increasing revenues, let's say 100%, there's no more you can increase on that. So let's look at other areas. Would it be fee for service, or where would it be where we could probably, like in other words, if the world's perfect, we can go out and just get any patient we want from any of our quote competitors, what would be the ideal thing to do? Would it be folks that have insurance that want to come to our system? We want more Medicare patient, more Medi-Cal patient. How would that work?
So the short answer would be this. So your healthcare system has a large amount of fixed cost.
Right.
So if we're able to see more patients with our existing cost structure, then we're going to generate incrementally more revenue.
Right.
And so when Vinod talked about our inpatient volume representing 3% of the growth increase in our gross revenue, what we've done is see our utilization of our beds go up. And so as our revenue goes up and we're able to manage our cost, then you'll see a closing of that margin between revenue and expenditures. So one of the initiatives that we're undertaking is reducing our cost per patient day.
Right.
And so if you're able to reduce your cost per patient day based on increased volume,
Exactly.
right? And,
Right.
and you see both decrease in cost and revenue coming into the system.
Right, because when we look at figure 12, showing in terms of increase, right, we see that our system and Stanford, I think, are the two that has some significant increase on patient days compared to all the other systems. As a matter of fact, if anything, I think Good Sam and RMC actually has less patient days. So in that model, just you mentioned, this increase of our patient days that significantly, technically, is a good thing for us because that is a significant increase in our revenue. Is that a correct read of what you just said?
It does help our bottom line. Those patient days, in terms of inpatient revenue, does go a long way to help cover our fixed cost.
If the revenues are higher than your variable cost, it helps pay some of the fixed costs. So the volume does help from that point of view.
Right. And I remember having discussion when Dr. Smith, our former county exec, was here, explaining to me how, for example, urgent care, the more folks we have on desk, that is the best for us because every person that comes in, we get a fixed dollar amount, even though they might be very minor ailments. So therefore, those are the higher margin work. So my question for you too is that still correct? And is there any way we could work on that area as well? If that's something that we could do well on our revenues?
That is correct, and that is because our clinics are FQHC cost-based reimbursed, and it's much more affordable care in terms of cost compared to an emergency room, and the revenues are there to help cover those visits. And so it's helpful from both a financial standpoint and from a healthcare standpoint relative to receiving the right care in the right setting.
Right, because I'm seeing more and more of these newer shopping malls where I see Sutter Health having their clinics right there at a mall where I expect lots of restaurants and retail. Suddenly, wow, why is Sutter Health there? Is that the reason why they are trying to get those type of customers?
Well, every system's different in terms of their strategy, and one can argue that they're trying to have a presence relative to capturing a larger share of the commercial payer market. So having it in a mall setting like that would be their strategy. It would not be our strategy, as an example.
Well, I think we are definitely more strategic in terms of where the locations. I've visited the one in Milpitas, I've visited one in Sunnyvale very recently this past month and seen the good work they're doing. I'm certainly concerned about the East Valley issue being raised today, but I would say the work we're doing is absolutely crucial. And I just want to thank you for running a really honestly, I mean, look at these numbers. I mean, we know St. Louis is going to go up, right? The need of South County is so huge, and we are planning for exactly that. And so the idea is that when we first bought O'Connor in St. Louis, there's going to be a lot of integration costs. It's going to be running more of a deficit. But as time goes by, we expect that many, many more people will be using, especially St. Louis, and therefore, both that increase of volume, we should be doing at least break even, if not positive, right? That's the goal.
Yes, sir. And I believe Mr. Williams is
Go ahead,
looking to
Yeah,
jump
I
in.
just wanted to make a few comments, picking up on kind of your comment about Sutter Health. I mean, I think it's, obviously we care very much about revenue because we need to ensure that our health system is in a position to be able to continue to sustainably provide critical access to health care. But we have such a different role, and you see that in the patient mix that we're talking about. But we're not a system that's trying to skim or focus on certain specific procedures like some private sector systems and hospitals do. We're also needing to provide comprehensive care, whatever that healthcare need might be, to folks who otherwise, don't have insurance or are Medi-Cal recipients. And we therefore need to make sure we have a system that's financially sustainable, but within a context that's just such a different fiscal picture than some of the private systems. And I think that's just worth keeping in mind because it is why some of our strategies look different, right? Why you might see a Sutter having potentially a mall-based strategy that's designed to target a different type of revenue model and approach that's really not at the core of the public service part of our mission, and why, for example, you see us focused more on things like increasing our Medi-Cal managed care population, where we then get those capitated lives. We do have full responsibility for their care, but then we, with that responsibility, have the ability to provide that holistic care, hopefully driving better health outcomes, lower utilization, capturing that revenue associated with the capitated payments, but working kind of holistically from that broader wellness standpoint for taking care of that population. And that's why I think you see that we have such a distinctive strategy. Then you have something like Stanford Healthcare, and they occupy a different part of the market as well, with certain types of even national specialty services as a piece of what they do. That is a focus of an aspect of kind of their revenue model. So I just think it's important to keep that in mind in all of these conversations, because it's why you hear us talk about the supplemental programs, Medi-Cal managed care programs, and a focus on some of the other things, including, as Vinod referenced, things like item 8 on today's agenda that just aren't at all a part of the conversation for these other systems.
Right. So when it comes to the other question regarding Medi-Cal, obviously we are expecting that there will be folks being dropped from Medi-Cal. The question is how many, and we're doing so much work right now trying to keep those folks renewed, right? Given the latest criteria. My question is, our county don't really deny services. Whether you're with Medi-Cal or not, we do serve them if they are sick, right? Is that correct?
That's correct.
That's right. So in that case, if those individuals no longer qualify for Medi-Cal, how would that affect our revenue picture when they come in and get care?
So individuals that do not qualify for Medi-Cal may very well transfer over to Covered California,
Right.
based on their eligibility, which I know Ms. Laura Rosas is working on to ensure that we're able to maintain those individuals within our healthcare system.
Right.
So it's not unusual for an individual to go from Medi-Cal to Covered California or some other program and end up back in our system or stay within our healthcare system.
Right. But in terms of our revenue side, would that increase, decrease, or would you say it's about neutral?
The way I would answer that is that when you look across the board in terms of our total number of patients that we serve, they're going to fluctuate on average between different programs. And so our goal is to make sure that we're providing the greatest level of access and optimization of utilization of our services. So whether we're receiving revenue from capitation or from a fee-for-service patients, as long as we're filling that last seat on the plane, we're better off as a healthcare system.
Right.
So that's
As
why
a
we
whole, no, absolutely, no.
That's why we
got
look at
everybody covered.
utilization.
We got everybody served, but we are, so in that sense, you don't really see a huge revenue hit by those folks being dropped out of Medi-Cal if they got covered California to pick it up.
We will see a revenue hit
will be,
relative to our capitation revenue. The question is, will we as a system be able to generate enough revenue to offset that? Because in this redetermination process, we're not talking about a few hundred lives. We're talking about potentially thousands of lives. And so that will have an impact on us unless we're successful in retaining them in some form or fashion. And that is why one of the agenda items today is talk about our Medi-Cal redetermination process and our effort to keep them covered in some form or fashion.
There we go.
And we can revisit that when we
Okay,
get to
when
that
we get
item
to
if
that.
that's
Okay.
agreeable.
All right, that's it. I mean, this is a big issue because at the end of the day, this is the largest expense issue of this county. And frankly, this is the most important part of the mission of our county's health and hospital system, how healthy it is. And I apologize for taking so much time asking these questions. I will have some follow-up. I don't want to belabor this point. But I do want to thank Paul for the good work and Dr. Sharma for trying to explain. I'm still the beginner here, trying to learn the individual portions of how we are able to get our revenue increased. And of course, any ways that we can maximize revenue is very important because so much of our cost is fixed, right? So much of it, not just the buildings, but labor costs and whatnot. So I think the deal really is we really need to get more patients in here, and whatever it takes to help increase the number of folks coming to our system, I think is something that we need to do a better job on the marketing because ultimately we have such a great system, but it's not known to so many people. When people talk about the word county hospital, there's always a negative connotations, which is unfortunate. But for example, the great work we have done at our burn center, our neonatal care, these are absolutely some of the best in the state, if not the nation. But that's not being well understood by the public. And I think it's so important. Our trauma care, of course, being the highest level. These are things that so many people don't know. And I think that's unfortunate. And I just want to make that point clear of how we could do a better job for marketing so that more folks would choose to come to us instead of thinking they're going somewhere better just because they have some big names behind them, like some university. Thank you.
All right, thank you very much. I think in light of the time, what I will do is simply indicate my continued concern to our county executive and to Mr. Lorenz on the growth in the deficit. Since we can only provide the service if the system remains economically viable, bringing that deficit under control, I think, is a necessary priority. And we've talked about it a lot, but it's a struggle. So to be continued. Supervisor, can I get a motion to receive the report?
Yes, so moved.
Motion by Lee, second by Semidian. Please call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Semidian.
Aye. We have the Behavioral Health Navigator Program up next. I just want to check in with Ms. Clara. We have the written report. I think there's just a minor typo on the second page where Community Services Agency dash Cupertino. I think it's supposed to be Community Services Agency Mountain View. Am I correct in that?
That's correct.
Okay. And then otherwise, Mr. Rao, I think there is a presentation that you are hoping to deliver, yes?
Yes, we have
Go right
a
ahead.
brief presentation, and we have Bruce Copley and Rosa Ortiz from our Behavioral Health Navigator program who will provide that brief presentation.
Thank you both. Why don't you go ahead and do that as expeditiously as you can. My lack of questions in a moment will only be indicative of the fact that I feel like I'm well briefed on this item and that your report is thorough and that I've asked a lot of these questions offline. I do note we have one card from a member of the public who'd like to speak, and let's just make sure that anyone who wants to speak from our virtual audience gets their hand raised sooner rather than later. Thank you. Welcome.
Good afternoon, Supervisor Semidian, Supervisor Lee, Bruce Copley, Behavioral Health Department. And I have Ms. Rosa Ortiz, who is the Program Manager for the Navigator Program, to answer any specific questions you may have. Next slide, please. So the vision of the Navigator Program was to provide a community-wide resource for individuals that are struggling to gain community services, could be health services, mental health services, but other social services that would provide them stability and work with their families. The Navigator Program is able to provide a more intense encounter with individuals and really work through what their problems are and offer them appropriate referrals. Next slide. The Navigator Program is found on our 1-800-704-0900 call center line. If an individual presses option 4, they are directed to the Navigator peer program services that are at the Center Road program. The peer specialists then work with the individual and again identify what the issues are and can over time provide them appropriate referrals and feedback on how best they can have their needs met. Next, please. We did a fairly robust community outreach. These are examples of the slides and flyers that we developed. These are also on our website, identifying the Navigator Program to the general community and how they can access it. Next slide. The peer support services, as a second phase to the Peer Navigator Program, we began to work with communities in identifying community centers where our Navigator staff could be placed to better meet the needs of individuals within the communities they live. We started with 5 programs: Los Gatos, Navigator Program in Mountain View, Sunnyvale Community, Peninsula Health, West Valley, and most recently, Milpitas is offering us a community site to have our peer specialists work in. It's been very successful in providing a program that is near where residents live rather than them having to travel anywhere, as well as to have face-to-face interventions with individuals. It really helps work through what their problems are and best how to provide them solutions to what their problems are. Next step. This shows a number of calls that the Navigator program has received since it began in July 2022. We're averaging somewhere around 700 to 800 calls a month. With each individual that we work with, we ask if they're willing to take a survey at the end of their work with the Navigators to identify what was working for them and how better we could improve the system. We're getting right around a 10% return rate. The average wait time for an individual to get a Navigator is under 2 minutes, actually almost at 1 minute. So there's a pretty immediate response for individuals that are calling the Navigator phone line. Next. This lets you see the survey. I mean, overall, individuals that have engaged with the Navigator program have been very happy and satisfied with the level of services they've got, with the care and attention that has been provided to their special needs. So we're very happy with the current ability of the Navigator program to really sync and work with the community at large. Next. There were 3 phases to the Navigator program. The first phase was doing the visioning and identifying how best to develop the Navigator program. And then in July 2022, 3 peer specialists were hired and worked out of the call center Navigator program. And then most recently, we have hired 3 additional peer specialists that are doing the field work that I identified within the various community centers. Next. We've been, on a quarterly basis, having a community stakeholder meeting to, again, get feedback on how we can improve the system and better meet the needs of the community at large. Our next meeting is October 19th. Next. With that, any questions, supervisors, you have for me or Rosa, we'd be happy to respond to them.
Sure. Before I call up our speaker on this item, to what extent does the program work through our existing clinics out in the community? Meaning Valley Health Center downtown, Valley Health Center East Valley, Valley Center Health Center Milpitas, and so on.
We are currently working with Milpitas Library, right across the street from the Milpitas VHC. We have not been able to have a, let's say, confidential space in the actual clinics because we want to make sure that we do have that space available for when individuals come and approach a peer, that we can provide that confidential setting.
And that's why the phone line is the primary vehicle for use for most people?
For now, yes, but we are at the locations one day every day, so we're there Monday through Thursday.
Got it. All right, Mr. Soto, we have a card from you, and let me check with the clerk. I don't think we have any other speakers on this item.
That's correct.
Thank you.
Yes, Paul Soto from the Horseshoe. I'm going to be as nice as I possibly can about this, but thank you for drawing the attention to that. You caught it, just like I did. Slide number 5, you look at all those spaces, and then when you look at the mental health care need per zip code, the greatest need is going to be downtown. But we got clinics over here in Palo Alto. We got clinics in areas that are affluent. Okay, and you don't have any statistical data as to why that is. Let me give you an example of what happened, of this kind of like perversion of the implementation of these policies. Measure A, when it was implemented, it was sold to the public that this block of money is going to be used in order to house the homeless, and we need to do that. And they sold all these pictures and everything. Dave Cortese did an excellent job, but they sold all this propaganda that it was going to service the homeless. The very first housing project that was built in Cupertino. 19 units in Cupertino. Now that's a con. I mean, we were just conned and we were lied to. Now we got these navigation centers in all these affluent areas, not one of them in the area where it is most needed. In the next sentence, you're going to talk about racial equity, you're going to talk about an equity policy, and we're going to talk about, Dr. Sarah Cody's going to come in here and preach to me again that racism is a public health issue. Well, it is. It is definitely a public health issue. The lack thereof. And so what she said was absolutely correct, and we have evidence of that now. We have evidence of that now. Because what I want clinics downtown. Downtown Clinic, East Valley Clinic, all of these other clinics. I mean, we can't continue to sit here and just continue to lie.
Any other speakers?
No.
Supervisor Lee, as you know, ordinarily I don't respond to public comment, but I just want to underscore or clarify something, and I'm going to use the opportunity to ask a question, actually a series of questions of Mr. Lorenz, so I want to let him know that. Mr. Lorenz, as you know, in the 5th Supervisorial District, which is the North County and the West Valley, there are 8 cities or towns that are wholly contained within the district, as well as a portion of San Jose. How many county health clinics are in Palo Alto that are up and running?
Valley Health Centers?
Yeah.
None.
How about in Los Altos?
No.
How about in Los Altos Hills?
No.
How about in Mountain View?
We have a satellite clinic there, but no major health center.
Okay. How about in, Cupertino?
No.
How about in Los Gatos?
No.
Saratoga?
No.
Montecito?
No.
So there is no full-fledged Valley Health Center clinic in any of the 8 cities in District 5 currently operating.
That is correct.
How about the portion of San Jose that is, the southern tip of the 5th Supervisorial District? Is there any clinic in that portion of San Jose?
No.
Thank you. Supervisor Lee, questions?
Yeah, just want to highlight the need for the expansion and staff increase of this important program. Certainly, the in-person service is still very limited, being once a week for half a day, right? And the numbers for the 2-month period are quite high. The service is provided to 33 community members, right, and provide programs to about 452 community members, which to me a loud signal that there's a huge need. So what we really need to go forward is to focus on expanding those hours, right, of service and staff. So I think that's one issue. The other issue I do want to mention is with the chart being shown regarding the BHS decentralized access number with the call center of the different options. I just want to highlight this one question. Is there are people who have asked me, if I see somebody on the streets clearly screaming for help, from the way they are walking in the streets, is not a family member, but you see somebody that clearly has got mental health issues, screaming for help. I mean, I was driving to work today, I saw somebody on the on-ramp off of between Central Expressway and just standing in a place where it could be very dangerous and definitely scream for help. Would it be best for them to just call 988, or would it be best for them to call the 800-704-0900 number in order to identify these issues so that help might be
So
arriving?
Supervisor Lee, they can call either number.
Okay.
They can call directly 988, or they can call the other number and they'll push one and they'll get 988, and that will then deploy the appropriate crisis team for the community outreach.
Great. Okay, good. I just want to make sure the word gets out there. Thank you very much. That's all I have.
And let me just ask, I note that a smartphone application is in development, yes?
We have not been able to find the leverage to do that. We have brought it up again on the table to see if we can get that started. However, we're again hitting a brick wall right now.
What's the challenge? I'm curious.
Financially, like when we come up and they ask us like, how much are you willing to spend? And we say, we don't have anything to spend. They're like, okay.
And I'm just curious, in the Palo Alto site, which is in the courthouse, and I'm familiar with that building, and I'm familiar with the fact that you have to go through a metal detector and security and pass, is that proving to be a deterrent? Is this the permanent solution? The Cumley Center would have seemed a possibility. Of course, the Cumley Center is relocating as a result of the housing project. So what's the thinking there longer term?
Exactly. So that's what we're facing as well. I am very passionate about providing the services in Palo Alto, but unfortunately, it is a hindrance right now because the only individuals that are going in there are individuals that are involved in the court system. So, but right now, the Court Cumley Center is located within that the courthouse, and that's where we're at. Basically, we're at the Court Cumley, the Kurt Cumley Resource Center.
Is the Cumley Center going to be relocated to new space eventually once tenant improvements are made?
Yes.
Okay.
That's correct.
And does that mean that there's a possibility then that these services, in whatever measure you can provide them, the navigator services, could be provided in that newly relocated space? I'm trying to be hopeful and optimistic here, but I don't want to, yeah, I'm getting a nod and a smile. Okay, thank you. Good. Well, I look forward to that, and I know you do the best you can in the circumstances. Supervisor Lee, motion to receive the report.
So moved.
Second, call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Simidian?
Aye, thank you.
Thank you, supervisors.
Thank you very much. Item 7, North County Clinic, which is a attempt to rehab an existing facility. Here today is?
Jeff Draper from the Facilities and Fleet Department, Supervisor.
And Mr. Draper, the facility that you're rehabbing was an office building, as I recall correctly.
That's
yes?
correct. It's a leased space.
Okay. And looking at the timeline, September 2023 was the estimated start of construction. How are we doing on that date?
That was the estimated start of construction. Unfortunately, we haven't got our building permit, but we expect it on Monday. So we would hope that the developer will start moving forward with the construction project shortly thereafter.
Okay. Who are we getting the permit from?
The permit comes from the county's Department of Planning and Development. We've called them.
Okay. I'm going to make a personal request of the county executive and his team to make sure that we are never delayed by a permit from our own county organization.
Supervisor, if I could take a moment just for a little bit of education. In this case, the designer is the landlord's designer. The designer has to submit, obviously, all the drawings and construction documents to planning and development for review. Sometimes those documents require substantial changes because of code issues, building code issues, and they go back and forth 2 or 3 times. It's really incumbent upon the design team to deliver a nice, clean set of documents, as opposed to requiring our planning and development department to keep reviewing the documents again and again.
I take your point. I would hope you would take my point that the turnaround time needs to be as close to immediate as it possibly can be. I understand there are other priorities, I understand there are other projects, but you know, frankly, it is hard to explain to people why things take as long as they take when we are our own permitting agency.
Well understood, sir.
All right. I think we have a mutual understanding, Mr. Draper. Thank you. I have no other questions and am happy to receive a motion to receive the report.
Immediately, so moved.
I will second. Let me see if we have any speakers on this item. I don't have any cards.
I have no hands.
All right. Please call the roll. Mr. Draper, thank you very much.
Vice Chairperson Lee?
Aye.
Chairperson Simidian?
Aye. Item number 8, Medi-Cal redetermination. And this report is going to come to us from Mr. Lorenz with assistance, I think.
Thank you,
And-
Supervisor. I believe Mr. Jarl will start off the presentation.
Thank you. And Mr. Darrow, before you start off, I was just struck as I was looking at this that, just so you know, it's really me. On the one hand, we've got this redetermination that is a source of concern. On the other hand, we've got a bunch of folks who are about to be eligible for, I think, the first time. So to the extent you and the rest of your team can speak to the sort of challenges of redetermination and the opportunities presented by newly eligibles, I think that would help give us a complete picture. Thank you. Go right ahead.
Yes, absolutely. Can you hear me? Good.
Yep, a little louder would be better.
Lean in, lean in. Okay. Good afternoon. Brian Darrow with the County Executive's Office. I'm here with Vinod Sharma, who is with the health system, and we have Angela Shing, the DEBS director, who is available on Zoom. We're here to provide our monthly cross-departmental update regarding Medi-Cal redeterminations. I wanted to quickly start with a few updates just following up from last meeting. As the committee knows, a great deal of outreach continues as we try to raise awareness about the Medi-Cal renewal process and about, we are starting to fold into that work some of the outreach related to newly eligible populations, as Supervisor Simidian alluded. That work is happening in partnership with many trusted community organizations. And at the last meeting, the committee requested information on some of those groups that have been engaged, so that list is included in your packet. Supervisor Lee at the last meeting encouraged us to do some additional outreach to the faith community. And I just wanted to report that Working Partnerships USA, which is helping convene our community stakeholder group, is really taking the lead on that deepening of outreach to the faith community. They've compiled and are now contacting a list of over 100 congregations within our county, including Hindu temples, synagogues, mosques, Protestant and evangelical churches, Catholic parishes, which we discussed, I think, at the last meeting, Buddhist temples, and many others. Manzi Kathuria from Working Partnerships is here today if there were questions on some of that good work. I did want to highlight as well, we have a subcommittee of the stakeholder group that's focused on small multilingual media outreach. I wanted to thank Supervisor Lee and his team. You shared a number of helpful media contacts. We've reached out to all of those contacts and have offered PSAs and opportunity for interviews, so thank you for that list. A couple more points. At the last meeting, information was requested about the fair hearings process for Medi-Cal redeterminations, and that information was provided in an off-agenda report, which is publicly available. And then Supervisor Simidian had requested some information on city-by-city data. That data is being compiled and validated and will be provided to the board off-agenda before the next Health and Hospital meeting, which is in 2 weeks, I believe. So that would be an opportunity to talk about that data. So that is my portion of the presentation. I did want, but our DEBS director is under the weather, so she has actually shared with me some high-level points that she wanted to make sure the committee was aware of. So if we could go to the next slide, I can share some of that information. So the slide here, we know it's a little bit of a complicated slide, but there's a lot of different dates that you have to track with the redetermination process. So I wanted to flag this data is as of September 8th. So we are still looking at an early data set. We are not quite through a full 90-day grace period yet to have final numbers for any one individual month. But you can see here for June, July, and August, as of September 8th, we are tracking around 80% approval and 20% or lower discontinuance, which is in line with our pre-pandemic trend. And that is very good news, actually, because a concern that we all had was that with the continuous coverage requirement ending, that there would potentially be a higher than normal discontinuance rate. And that worry is because if you think about it, instead of going through the renewal process 1 year after you last did so as a Medi-Cal enrollee, you're now going through the renewal process 4 years after you last did that. So the likelihood that your life circumstances may have changed in a way that could affect your eligibility, be it you moved out of the county or there's an income change, that likelihood has probably gone up over 4 years. So we were worried that the numbers could be lower. So the fact that we're tracking close to or even beyond historical numbers is actually good news. I will highlight we are still early in the process. So it's a little too early to tell how everything's going, but those overall numbers do give us some confidence. Now, if you look at the bottom left corner of the slide, that's a different way to look at the data, and it is based on our renewal rate of return. So you'll see that the overall numbers in the upper left actually factor in auto enrollments, but as far as renewals go, we're doing very well compared to history in terms of timely renewals. We're seeing a little bit less in terms of late renewals. So looks like we'll land for June pretty close to the historical rate overall, but again, the overall numbers when you factor in auto enrollments are probably going to actually be better than history. So that's where things stand, still cautiously optimistic. I would add just a couple things about the newly eligible population. It is the largest of the recent expansion, so we're talking about 26 to 49-year-olds who are eligible, or eligible from an income standpoint, but previously have not been eligible for Medi-Cal from an immigration documentation standpoint. And so that population, a large section of that population we've learned is already, and there's been an effort to do this, is already signed up for restricted scope Medi-Cal. So our strategy has actually been to try to enroll as many individuals in that population into restricted scope, and then they can immediately convert into full scope Medi-Cal on January 1st. And so looking at our numbers, we actually believe, and SSA will correct me if this is inaccurate, that 38,000 individuals fall into that category because of the push to sign people up for that emergency Medi-Cal. And we are working to try to sign folks up early from our PCAP program onto the emergency Medi-Cal for just that reason, so that it'll be a seamless transition in January for as many community members as possible. And with that, so this numbers you see here are the county-wide numbers. Now I'll turn it over to Vinod Sharma for the county health system numbers.
Before you do, the distinction between restricted scope and full scope, what is restricted scope?
Well, that's where my expertise definitely runs out. But I know there's, I don't know if Mr. Lorenz could answer the question in terms of what benefits are covered and for how long when you are on a restricted scope enrollment versus full scope.
Is this Medi-Cal Light? Is that what it is?
Yes, basically.
And who's eligible for it, and why are they not eligible for the full program?
I see Michelle Delacaya jumping in here, if you don't mind, Supervisor.
Hi.
Sure.
Good afternoon. Restricted Medi-Cal would cover for those folks that are pregnant or needing emergent inpatient care. It does not cover for primary care or preventative care.
Okay. So the folks that are in that age bracket that will now be eligible, did I understand you, Mr. Darrow, to say that you're trying to get them signed up for restricted scope now, or Ms. Delica, whoever, you're trying to get them signed up now so that the pivot is a quicker and easier one come January 1st? Is that the...
Yes, it's actually seamless, so they will automatically convert to full scope Medi-Cal from restricted on that date.
So essentially, it kind of allows you to get a head start on the process.
Yes.
And did I hear the number 38,000?
That is the number that, yes, that is the number that's been reported to us from SSA. And that is, again, the county-wide number, not within our health system, but the county-wide.
That's correct, yeah, about 38,000. I don't know if you guys can hear me.
Oh, Angela, I don't think we heard that.
Yeah, can you hear me now?
Just barely. If you can try and
Yeah.
improve your audio, that would be helpful.
Is this any better? Can you hear me now?
A little
Yeah,
bit.
and just-
Go ahead.
I'm just confirming that, yeah, the number's just about 38,000 that are currently on restricted scope.
And that's out of a total of how many that will be newly eligible?
That's oh, go ahead.
Yeah, that is the number that's currently on restricted scope, and they will transition to being full scope on January 1st. So that is the total number. And then starting January 1st, new people could enroll also.
Is that Ms. Shing I'm hearing from back there? Yeah, Ms. Shing, what
Yes.
I'm trying to discern is that 38,000 people, that would mean it's not everyone who will be newly eligible January 1st, or is it? Have you got 100%? That doesn't sound possible.
Yeah, that is everyone who, how it works is everyone who, basically undocumented individuals who are currently on the program are currently eligible to restricted scope Medi-Cal. So on January 1st, they will automatically transition to full scope Medi-Cal. And then on January 1st, people will then just be eligible in that immigration status, will just be eligible starting January 1st and can just apply as normal.
All right, I think the audio is causing problems, but Mr. Darrow, I think you can understand, my understanding is that you said earlier, we're talking about folks who are 26 to 49 years of age. Did I get that right?
Correct.
And that their immigration status has been the impediment previously.
Primarily.
And so what I'm trying to get a sense of is, have we actually signed up 38,000 people for restricted scope Medi-Cal?
Yes, that is my understanding. I would just to add to what Angela was saying, the denominator is harder to know, which is what I think you're asking, which is 38,000 out of how many who are eligible in the entire county entirely for this new program. And that number it's actually heartening what we've seen. So we asked the UC Berkeley, actually Working Partnerships did, the UC Berkeley Labor Center, to try to estimate the number because it's not a precisely knowable number, but they were actually estimating pretty close to the 38,000, maybe just a bit right in that ballpark. We know that there is a few more folks than that, from my understanding, because I believe not everyone on the PCAP program right now who's in the eligible income range, because as you know, PCAP actually goes higher than what Medi-Cal income levels are, but the folks in that range, I believe not everyone is on restricted scope Medi-Cal currently. So there's a population there that we need to get on the appropriate program by January as well. So, but I think we're actually not too far off, but clearly there needs to be continued effort because we're not going to know for certain that we've gotten everybody. So it's a new program. We have to do a full push to make sure we can reach as many people as possible.
Thank you. I'm sorry to interrupt your flow of thought, but I was baffled and am still a little unclear about, to use your phrasing, the denominator, like 38,000 out of what total potential pool. It sounds like the answer is that may not be a knowable thing, but we think like 38,000 is a really big percentage of the folks who will ultimately be eligible for full scope Medi-Cal on January 1st. Did I get that part right?
Yes.
All right.
And one more, the other thing I'd heard, I think we can try to get a better number too, but what I had heard is with the last expansion we had, which was the 50 and older population, was about 12,000 folks, new folks who enrolled?
Yeah, that's correct, Brian, yeah.
Just for
and to give context, we're just putting the numbers together now. I think when we did the expansions for the youth, on the kids, youth, and then 50, each population was about 5,000. The over 50 was about 15,000. This is by far the largest population, and it will complete so that essentially everyone is eligible for full scope Medi-Cal. So this is really a historic change.
All right. Thank you very much. Please continue with the remainder of your presentation. I'll try and hold myself back.
Good afternoon, Supervisor Samitian and Supervisor Lee. For Santa Clara Valley Healthcare, our effort is direct outreach to the people. We are working with them on the phone and in person, helping them complete the application packages and send them to social services. Up to date, we have about 10 or 11,000 people we have already assisted, another 6,000 in the pipeline. Thank you again for giving us the 15 unclassified positions. We will start working in hiring them because as fall comes, which is already there now, we will see higher volume, and this would help us prepare for that and also prepare for what comes in January when the expansion happens. So the other thing I want to show there is on the bottom of that chart is a table which tells us what is the status of the delegated lives. These are the lives where the capitation revenue, which is approximately $400 million this year for us, that is coming through them. 168,000 lives in June, and till date, we have lost some and also added some more to the enrollment. The net effect is 1.4 since June, 1.4%. It's about 1,400 some net change. That's about $1 million of revenue impact. We hope this number is going to be in this range. It's not going to increase because there may be slight increase, but then again, when January comes, it will see some effect of the expansion that as the more members are added, our revenues will improve. And so 1.4 is right now what we have, the net effect. We were expecting a much larger impact when we first started working on it. So this number is encouraging. Any questions you may have?
Supervisor Lee?
Yeah, thank you very much. First of all, I'm very glad to hear that the information regarding the interfaith and also the media has been used, that we have been able to access a lot of the folks who might not have the language capability or use the normal media channels. So I'm hoping that would get the word out there, and I've seen them, some of these other channels in other languages, so I'm like, aha, it is working. So thank you for doing that. Second question I have is regarding what we just talked about earlier, is for those who are dropping off. When you look at those who are dropped off, I would say more than 85 or 90% is due to the failure to return. The number that's truly, they return but it's ineligible is actually about 10% of those who are dropped off. That's a correct read, correct?
That sounds pretty accurate.
Right.
Yeah,
So
the majority is due to failure to return, yes, yeah.
right. So first thing first is, for those who fail to return the material for re-up, how are we trying to reach them short of sending somebody to their house or last known address, knock on the door like we did for Palmatoras for the COVID vaccine, right? What other ways can we try to reach out to them, or do we even do that?
Thank you for the question, Supervisor Lee. There's a number of strategies happening. The Social Services Agency, DEB's side of the house, is contacting everyone in that population who are still in the 90-day period after they've had lost the coverage, but are still able to get coverage back without a full new application. So they are contacting folks via text message, robocall, email, and they're doing that every month of the 3 months. And actually, it's actually 4 different contacts throughout in each of those modes, and they're doing it in multiple languages. But I think right after discontinuance, like basically 2 days after, is when the first message goes out, and then mid-month, each of the next 3 months. We also have a number of community organizations who are, as part of the state's Navigator program, who are obtaining contact information from the state, from DHCS, on who is in the 90-day period, and they are doing live calls to those individuals. Fortunately, we were worried that there might be a lot of duplication, and there's some, but they're actually splitting up those lists among the grantees for the most part. And then one of the biggest pushes that's happening and will be enhanced soon, I believe, and Vinod will correct me, is within our own health system, we have that strong team in patient access with 28 FTEs who are doing very active outreach to everybody who's coming up for their due dates coming up, but they're also doing outreach now to the folks in that period after they've lost coverage, the 90-day period, and they're focusing on people who are coming closer to the 90-day period. But thanks to your board, your approval of the 15 positions, unclassified positions, it's going to really help with that 90-day outreach. And those are live calls. It's also, right across the street from Valley Medical Center is the patient access building where if, calls are made, and then if you need to come in to get help with your application, they're providing that assistance there. Or if you want to submit it online with the assistance of someone on the phone and do the DocuSign, they do that. They're very flexible, good linguistic access, and so there's a number of different modes, I guess, is what I'm saying. Anything to add, Vinod?
Yeah, the primary focus for the SCVH outreach is to make sure that we are able to retain those 167,000 members as much as possible, and also those who were seen at the hospital for specialty services during the last 3 years. So that effort is taking place, and then what happens is they also look at, as it comes to the closer to the end, they start prioritizing those who have not yet returned the packages. Once the 90-day is over, they would lose their coverage, and then they would have to be re-enrolled if they don't have any other options. The idea is to catch them before.
So we mail them, right? That's done first. No response. We text them multiple times. We have live calls, but we don't knock on the doors, right?
No, not at this point. To my knowledge, I mean, I don't think any of the grantees are currently doing that. It's more focused on calls. I think one of the challenges with that is just how geographically spread the folks who happen to be coming up at that moment for their renewal are. So it makes it just from a resource standpoint a challenging approach. Whereas with COVID, we had a great success, as you know, with a little bit of different dynamic, trying to go door to door for vaccine and other outreach.
Yeah, the reason I asked that question is because as oftentimes we know I don't answer calls that I don't recognize phone number. And I think that's just how much spam we're getting from our phones. So phones has not been that useful. Even texting, half the time these are spam texts. They claim they have millions of dollars for me to pick up, or how certain things is going to drop if I don't call them back, which I know is not true. So I'm just afraid that people see our messages, not truly understanding that truly we're the good guys, for example, right? So that's why I'm thinking maybe whether a visit might be possible. I know the resource is one issue. How about connecting to a nonprofit, our nonprofit partners, to see, is it possible for us to provide certain names to folks in a certain region if we just put them based on zip code, let's say, right, from folks, and nonprofit that serves that area, let's say, would be able to get, hey, these are guys, if you could contact them, let them know that they're going to get dropped Medi-Cal. Is that something even possible?
I mean, that's kind of how the Navigator program is envisioned to work.
Right.
We have Community Health Partnership, Healthier Kids Foundation, California, CalCHI, I can't remember exactly the acronym, the Community Health Initiative, which is CHI. So those are two different organizations, although affiliated, and then Catholic Charities. And you know, there is different groups have different approaches, but I know, for example, CHP, when they're doing live calls and then also sending text messages with a phone number, which sort of identifies who they are, of course, and then here's a phone number to call back, and it's a quick line to get through. I know our own patient access in the health system, they've actually had some success leaving messages where they leave a voice message, and they've been able to track that because they give they leave a voice message and then say they're going to follow up by email and provide a DocuSign way to submit your application, that they've actually tracked a number of emails coming in from folks that they didn't even have a live conversation with that have successfully gotten re-enrolled. So there are, fortunately, some folks do still check a voicemail. I feel kind of rude when I leave someone a voicemail now sometimes, but I know people do check their voicemail, and so we're trying out a number of different approaches.
And one of the things we have done is the team is working little later in the evening so that people, when they return from works, can attend to the phone calls.
Oh, no, I don't disagree that phone call is much more efficient and effective in some ways, right? But different people, different ways of reaching them. Just go back to campaigning, right? Why do people get those shoes and spend hours knocking on doors, talking to voters, right? There's a different communication means or mode that is still very effective these days. So I just don't want to completely give up that mode of communication to folks, because they're ignoring the mail, they don't read the mail, they're ignoring the phone calls. Just because of the fact that we don't have the resources, we're not even trying to at least reach some of them in person. That's what I'm trying to say.
Supervisor
Yes.
Lee, thank you. We have had some discussions about high-density housing areas and looking at zip code data in the failed to respond or return the packets. So those are things that we're actively looking at and working on in partnership with the community partner agencies as well. So those are things that we're looking at and helping educate the folks that are on the site at the high-density housing areas as well. So
No,
working on
that's
those.
great, and I want you to continue doing that. And if you actually do go out there and do some doors knocking, if you can keep track of those numbers, I would love to see what those numbers are like.
Great.
I mean, just like running campaigns, we always have how many calls have you made, how many contacts have you got, how many doors you knocked on, and frankly, I would say you'd be lucky to get 30% of people open the door for you. But the fact that you go by the door, you leave the material, that's another touch. And when campaign's over, you see the result. Those who walked, those are the districts that you definitely get better results. And I think that there's no different here. So I just want to make sure that we don't forget that part. And it's definitely resource intensive, I understand, but we obviously have tried everything else. I just want to make sure that's not the last thing that we didn't try, number one. Number two is going to those who are now during their packets but are now ineligible. How many of those, or if you are tracking that, are being signed up to, for example, we talk about the Covered California, or how many of those are going to PCAP? Do we measure it that way?
I would actually, I don't have those numbers, but I know that, I don't know if, Laura, you want to weigh in. I think a lot of folks are getting auto-enrolled, if I'm not mistaken. Is that correct?
Microphone, please. Thank you.
My apologies. They are moved over to Covered California, but they still have to effectuate some part of that because it's a contract between them and Covered California. So the state can't just enroll them. But they are sent over. We are also making phone calls. We're also working with patient access. We've made about 440 phone calls so far. We got another 1,200 we'll make. So we're working really closely to try to make sure that they understand that they've been enrolled, they understand, or that they've been moved over to Covered California. There was education there, and making sure that if they have not returned the paperwork, that they understand they have to contact their eligibility worker at social services. So we're working very closely with the health system on all of this.
And when you say you auto-enroll, does that happen after the 90-day grace period when you do that?
It can happen at any time. As soon as they are sent over to Covered California, they have 90 days to do that.
Right.
And there are actually some subset that are below an income level that they'll just be put in. So they're trying to really look at the most vulnerable.
Right.
But they do have to complete a small piece of this, so that in most of them will only pay as $0 or $1. But if they don't actually complete the paperwork, they're not going to stay in Covered California. So there is a one piece. So we're trying to reach out to them and make sure they're actually completing all of this.
So Laura, you talking about those who failed to return, or are you talking about those who are eligible when it comes to the auto-enrollment?
So if they have been termed out of Medi-Cal, they have 90 days, right? We are contacting those folks.
So all of them, whether they return the package or failed return, they
Right.
still get that
Right.
other part that you come in, right?
Because we don't know
Right.
what their situation is.
Exactly.
Have they received the paperwork, not received it, sent it in, do they understand? So we're also working with the group at Patient Access as well.
How do you track how many of those have been enrolled or not? Is that tracked?
I'd have to check on that. I know we made like over 400 phone calls so far. We're receiving lists, and then we are making the phone calls. And it's not, to your point about the phone, it's not the most effective way, but there isn't, because of federal texting regulations, there's a lot of restrictions around texting, for example.
Is it possible for that number to be reported back to us in the future? When these
Absolutely.
come back?
Yes.
Yeah, on a monthly basis. Yeah, I appreciate it. Thank you very much. That's all I have.
Thank you.
All right, thank you. And I don't have any additional questions after I interrupted the team to make sure I understood the implications of restricted Medi-Cal, and thank you for the restricted scope Medi-Cal. Thank you for the education on that. I sitting here thinking, I can't believe it. I just learned that today. It seems like that's something I would have picked up on earlier. But let me just ask, if at some point you feel you have been able to garner clearer data about the totality of eligible folks out there in the population, please share that with us in an off-agenda report. But it sounds like, based on the best estimates, that 38,000 is really quite an extraordinary accomplishment for a restricted scope. So thank you for that, and thank you for the effort. I am guessing that, as with almost any effort like this, there's a certain diminishing marginal utility of further effort. That getting the 98th out of 100 is a whole lot harder than getting the first 5, 10, 15, or 20 out of that 100. So understood. Supervisor Lee, the only recommended action here again is to receive the report. Can I get a motion?
So moved.
And I'll second. And I don't have any cards. Let me just check and see if we have anybody online.
We don't.
We do not. Then I will say thank you to the team and ask that the clerk call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Simonian?
Aye. That is item 8. The motion carries unanimously. Thank you. That takes us to item number 9. This is the report on our Child and Adolescent Psychiatric Facility / BHS Center, Behavioral Health Services Center. And see, Mr. Draper has already found his way down. Why don't we ask you for your report? I think it's pretty straightforward, and thank you, Mr. Draper.
Yes, sir. I think Doug Koenig is on the line. Doug, are you there?
Yeah, I'm on the line. Good afternoon, Supervisor Smitty and Supervisor Lee. Doug Koenig, Deputy Director, Capital Programs. Only have one update to the report in front of you, and that's that we had originally planned on presenting the change order to the Board of Supervisors to establish the guaranteed maximum price at the first meeting in October. It's taken a little bit longer than we thought it would to put it together, and we're now targeting the second meeting in October on October 17th.
Okay.
In coordinating with the contractor, we don't anticipate a significant difference in the GMP from the current guaranteed not to exceed amount. With that, are there any questions?
I do not have questions, except I will comment that looks like we are on track, that the project progress and schedule of delivery is the same as last month. I'm reading that correctly, yes?
Yes, Supervisor
All right.
Smith, that's correct.
And
We're on track.
I heard you say that while it may take an extra meeting to get the guaranteed maximum price number in front of our board, that the number is likely to stay in the same ballpark. Yes, that's just a function
Absolutely, that's correct.
of the time it takes to move the process along, not a issue around the amount. All right, then. Well, what I will do then is, since the only recommended action is to receive the report, I'll ask the clerk, do we have any speakers on this item, either in chambers or online?
I have no requests.
All right, then we have no speakers. Then I will say, Supervisor Lee, thank you for returning on a timely basis. Can I get a motion to receive the report?
So moved.
Second, call the roll, please.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Motion carries unanimously. That takes us to item number 10, which is the mental health access for the West Valley. And who's going to present on this one?
Thank you, Chair Submitting, Michelle Delicaya with our Office of Integration.
Thank you. Ms. Delicaya, go right ahead. Welcome.
Good afternoon, Chair Smitty and Vice Chair Lee. Michelle Delicaya, Director of the Office of System Integration and Transformation for the health system. As noted in the written report, and the health system continues to partner and identify opportunities for expanded mental health access. You heard today about the mental health navigation program expanding into the West Valley. And Santa Clara Valley Healthcare has begun work on designing for a clinic site at De Anza. And ongoing as well is both behavioral health and Valley Health Plan are continuing to dialogue and network and consider network expansion across the county, including telehealth options. And with that, I'm here for questions.
Thank you very much. Supervisor Lee, I have some comments and questions, but let me defer to you if you have any, and if not, then I'll pick it up to me. All right. Do we have any cards from speakers on this item?
We do not.
All right. Ms. Delicaya, I'm going to tell you how I see this. You don't have to agree. I'm just trying to be clear about how I see it. I think we have, first of all, I want to say I appreciate the efforts that have been made. I should recognize those to get trust out into the West Valley, to get some of the behavioral health navigators. You know, half a day, once a week is, you know, not what I'd call a big footprint, but it's progress. So we're making the progress, and I want to acknowledge that and say I appreciate it. That said, what I take away from this report and from the others that have preceded it is, gee, we'd like to do more in the West Valley. We acknowledge that there's a need, but you know what? There just isn't anybody to provide the darn services. That's my takeaway from the report. And with that in mind, you all have suggested that there be what I think you call a regional approach. Am I remembering the terminology, or is that just my characterization? And I think that that's fine as far as it goes, but I'm not very optimistic we're going to make real progress on this unless there's a real plan and a real timeline. And as we've discussed in other portions of the agenda, sometimes even where there's a timeline, the timeline slips. Fair enough. But I do think we need a plan and a timeline. So let me look to Mr. Lorenz and Ms. Terrell and you, and maybe even the county executive if he wants to lean in, to say, when's a reasonable time for you to come back and say, this is our plan to actually deliver some tangible, improved, increased direct services in the West Valley in the mental health space?
You want to go first? Supervisor Simidian, so one of the things that I think we're grappling with is to what extent, beyond the current services that we're offering, the board would like to go. The expansion of services would go beyond what we've currently proposed relative to the De Anza site and the Mountain View location, which is opening up July of next year, which would include behavioral health services, mild to moderate. In that situation, we will continue to work with our counterpart in behavioral health to see how we can partner to supplement the programs that they currently have in place. We would also then work with Valley Health Plan in terms of ensuring that we're part of the network and ensure that services are available. Beyond that, I think we're looking for further direction from you and the board.
Well, I think, I mean, I can go back and look at the referral that we did that did ultimately get support from the board. and if I remember correctly. And the challenge, of course, is that the North County site right there on the border of Palo Alto and Mountain View is not a site that's going to be terribly useful to people in the West Valley cities, the 5 West Valley cities. Now, is it possible that folks from that site, once it opens, could in fact provide services in a location to be determined, TBD, in the West Valley, but use the North County site as their headquarters? And let's be candid here, the De Anza site is a long way away from completion. So I have appreciated the fact that people have acknowledged the need in the West Valley and acknowledged that ultimately if we can get the De Anza site actually approved and built, that services might be provided there, but that's years away. I know it. It pains me, but I know it. So what I'm asking myself is, are there contractors with whom we can contract to provide services? I don't know if that's, what's Pacific called now? Pacific, somebody help me?
Pacific Clinics.
Pacific
Clinics, you're referring
Clinics,
to
yeah.
formerly
or,
Uplift.
Or formerly Uplift, formerly Eastfield Minquang, formerly
Yes.
QMC, formerly, time passes. Or the folks at Cassie, who I did not see referenced here, or the folks at Momentum, who I know have a large footprint in our county. I get, again, that trying to contract with folks who can't hire anybody is a challenging task. I get that. But I feel a little bit that people have just sort of thrown up their hands and said, nothing to do. I don't believe that, and I'm not prepared to accept it, at least not today. So I'm asking if we can get some kind of a plan to actually deliver some real services to people who need help in those communities. And the reason I went through that painful exercise with you, Mr. Lorenz, and thank you for your good humor in accommodating me, is, I think there's always a fair debate about what level of services are needed in what location, but what part of zero are we having trouble coming to grips with? Because there isn't anything in the way of a county health clinic in any of those 9 cities, let alone mental health, with the exception of a couple of suites and a pharmacy that we've piggybacked with Planned Parenthood on. So I'm happy to give people a little room to rethink it, come back with a plan and a timeline, but I'm not comfortable saying, well, gee, it's hard and we're just going to give up, because I kind of feel like that's where we're headed if we don't say, let's try.
Well, I think we can continue outreach to these contractors and come back with a plan to see what service expansion they're willing to contractually commit to in the West Valley.
All right. And
what that would cost and what timeline that would look like.
Thank you. And I'm going to look to my office, and as I wish Dr. Rudman were here so I could tease her. We're sort of between staff on the healthcare side, because public health stole away our healthcare staff, or fair enough. But I'm going to turn to my staff and say in an open public meeting, please have me get on the phone to Supervisor Lee's comment about, and actually have the conversation with the 3 organizations that I mentioned and any other, and just say to them, look, I'm asking you to find a way to deliver services in the West Valley. And, I just, I'm not thinking that's I wish it were a magic remedy that I made the phone call. I know it's not from past experience, but I think anything that I can do to put my voice alongside that of our professional staff hopefully will only be helpful. I'm obviously not in a position to make proposals or negotiate over the telephone with providers, but I do want to try and communicate to them the seriousness of the situation and the need for these services. And so, Mr. Williams, I heard you say, can we pick some kind of a date by which we'll have a plan and a time, even if it's to come back and say we have made no progress? I just feel like letting this linger is not going to do any good.
I would say December.
December it is. We'll see you at the December HHC meeting, and I will thank the county executive and the rest of the team for their willingness to step up. And Ms. Delakai, just so we're going to end on a positive note, thank you again for the work to bring trust and the Navigator program to the West Valley, and for the eye to a longer-term set of services that's more robust in the West Valley, where the services are clearly needed. All right, thank you. Anything else, Supervisor Lee? Any public speakers? No. Mr. Rao, didn't want to preclude you from leaning in on that one if you wanted to.
No, I understand what we're going
Okay,
to be doing.
good, thank you. Then we'll ask for a motion to receive the report.
So moved.
I'll second. We'll call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Simidian?
Aye. All right, that takes us to item number 11, which is a bit of a catch-all item. Do we have speakers on item number 11?
I have no cards, and so far, no hands.
All right. We have slightly reorganized this section in the aftermath of restructuring in the county executive's office. I noticed that 11A is to receive a verbal report from the County of Santa Clara Chief Operating Officer. Are you pinch hitting for your Chief Operating Officer, Mr. Williams?
No report, but happy to answer questions.
All right. None from me. Supervisor Lee? None. All right. That takes us to 11B, which is the report from the Chief Executive Officer of Santa Clara Valley Healthcare. Mr. Lorenz, I believe that would be you.
Yes, Supervisor. So in the report, you have a number of different operational updates, one of which I would draw to your attention is the diagnostic imaging work plan, which covers upgrading our Valley Health Center imaging equipment, both for breast as well as general diagnostic imaging, along with an update regarding the hospital equipment.
Got it.
So with that, I can take questions.
Thank you. Thank you for all of the various responsive reports in 11B, including that one. It does look to me like the, before we get to the diagnostic imaging one, the clinic offices that we have in Mountain View are not yet at anything like capacity, but that you're at work on that. Is that a fair summary? I'm looking at my packet page 85, 11B, if that helps you. Report on 2500 California Street Clinic in Mountain View. I see that we had a cardiologist hired and a
Apologies, having trouble hearing you.
pulmonologist started recently, but that we're looking to recruit other specialty providers, if I'm reading the language correctly.
That is correct, Supervisor. I feel good about the progress we're making. The cardiologist that we've hired rotates to the North County so that patients have much easier access. The cardiologist is there 2 half days a week and seeing 8 patients per half day, which for a specialist is good. And as the volume continues to increase relative to the referrals, we will expand his availability. And as you noted, pulmonology is also being offered at that location, and we are looking at other specialties, including ID, neurology, and rheumatology.
Thank you. Are those, when you mentioned the referrals, are those referrals of coming from Planned Parenthood, which was, I think, one of the things we envisioned, but certainly not the only possibility?
The referrals are coming from our own health centers for patients that live in the area, as well as community health partnership clinics, which includes Planned Parenthood.
Got it. Thank you. Then as to, and I'll make this relatively, I think, quick and easy. Mr. Williams, I have been in touch with Mr. Lorenz about this issue of diagnostic imaging, and I appreciated it. There was a lot of good work already underway, and I want to acknowledge that. That said, I am hoping in the aftermath of the discussions we've had this month about dense breast tissue in particular and the changes at the federal level, that we use this occasion to step up and do even more. And this goes to some of the earlier conversations, Supervisor Lee, that you prompted around the fact that early detection really does actually have not only health consequences that are beneficial, but also financial consequences that are beneficial. I guess the easiest way to say this, Mr. Williams and Mr. Lorenz, is my goal is to see what we can do, as we did with PCAP and as we did with Medisys, to make sure that diagnostic imaging of the right type, understanding we've moved from film mammograms to digital mammograms to tomography 3D to, in some instances, ultrasound and MRI, that diagnostic imaging is available to every individual, mostly women, but sometimes not, to every individual in this county, regardless of income or geography. That's sort of my shorthand. And the regardless of income or geography is designed to speak to the group that I sometimes refer to as the missing middle again, working folks who are perhaps not eligible for Medi-Cal because they make a bit too much, but even if they make a bit too much, are not in a position to access high-quality, full-coverage insurance. And I will come with a referral on that at the November 7th meeting, which I believe is the only meeting in November. And I will then ask for a report back in 60 days, and that report back in 60 days will mean first meeting in January, depending on when the first meeting is, which is not yet scheduled. I just wanted to sort of let folks know I am not springing that on Mr. Lorenz. He has been kind enough to spend some quality time with me, which I appreciate, talking about my interest in this area. And again, to sort of say, well, okay, that was a lot of words. What does it really mean? What it really means is any woman in this county, regardless of income or geography, should be able to easily access the diagnostic imaging that's necessary to keep her health. And that's what I'm seeing if we can't maybe do an even ever better job on. So with that, I will say, Mr. Lorenz, did you want to weigh in on that at all? Or feel free, and or Supervisor Lee.
Thank you, Supervisor. I think your direction is clear. We'll wait for the referral and respond accordingly.
And then that would I would say thank you, and that would take us to item C. Oh, excuse me, Supervisor Lee did want to lean in. Go right ahead, sir.
Thank you for the great report. Lots of good ideas, and also read about the concussion clinic. Just a suggestion is, I wonder if we should outreach to the 49ers, because as we all know, for football injuries, there are a lot of need of that, and I think making it aware to the players over there, I think could be helpful, or even to our schools where they have that sport. So I just want to make sure that that connection is being made, and who knows, maybe they'll come visit, and we might increase some patients, and maybe even want to get some increased revenue through donations. Who knows? Thank you.
All right, duly noted. That takes us to C, under 11, Public Health Officer, but the Public Health Officer has given her report on COVID and flu and the latest and greatest in our virus pantheon, so we will say thank you. I think that one's covered. That takes us to behavioral health. Ms. Doral?
Yes, good afternoon, Chair Samiti and Supervisor Lee. You have my written report. However, I know you requested that I address the public comment from earlier today. So wanted to provide a brief update around that. We have shared with the full board our updates related to CalAIM payment reform, and have highlighted several of the changes in previous reports that our system at large has been required to have in place effective July 1st of this year. We have been working very closely with our contractor agencies, meeting with a small subset of the Behavioral Health Contractors Association leadership group on a every other week basis since the latter part of the last fiscal year. Recognizing that some of the agencies are in fact raising concerns around cash flow issues we immediately sent individual emails to all 28 agencies indicating the number of claims received to date, highlighting the error percentage of those claims, as well as acknowledging whether the agency has requested and received an advance payment. We did allow, through our contract, a 15% advance on the contract to any agency that wanted to request that, as well as offered additional percentages on that advance if necessary. We've heard back from 22 of the 28 agencies. And of the 22 that we've heard back from, 6 agencies requested a meeting sooner, indicating that there may be a bit more urgency around their financial situation. However, it is important to acknowledge that the remaining 16 that we have heard back from did not ask for a meeting immediately. So I think what's really important to highlight here is there are very unique circumstances impacting each individual agency. And so while I think the public comment earlier might have sent the message that this is impacting all agencies equally, that's not the case. Certain agencies are in better standing than others. We know who those agencies are, and we're working individually to address their individual needs. So we do have those meetings planned for this week and next week. And we'd be happy to provide, a follow-up off-agenda memo probably in about 3 weeks that can provide the full board kind of an update on where we are with respect to CalAIM payment reform and our behavioral health contractors.
Supervisor Lee?
No, thank you. This is very helpful. Sure. What is the bottleneck? And exactly, is it because of the fact that these are new systems that folks are not used to the new system implementation? That's why errors are being caused? Or what are the reasons why after claims are submitted, they cannot be paid sooner?
Yeah, so in the prior fiscal year, we were between an 80 to high 90% acceptance rate of claims. However, with CalAIM payment reform, we've highlighted a couple of significant transitions that we understand, impact the entire system. One is there was a coding transition. So formerly, agencies would bill services and claims through what we called HCPCS coding. That changed to what we call CPT codes effective July 1st. So that required agencies to adjust the way in which they submit those claims using CPT codes rather than HCPCS. We worked closely with the agencies in the latter part of the fiscal year. You'll recall we hired an agency, UASI, that is a consulting agency that provided training to all of the agencies on CPT code billing. And we've also continued to provide regular consultation to each of the agencies related to that transformation around the coding. Secondly, I've been providing in my monthly report here to Health and Hospital the transition of agencies to be able to bill through our NetSmart My Avatar system, and in the monthly reports have provided updates on the cadence for all 28 agencies to be able to submit those claims through NetSmart My Avatar. And effective the latter part of the fiscal year, all agencies were able to bill through that. And just as a reminder around that, CCPs submit services provided to the clients as claims to the county for payment. And the county has set up what we call a claims adjudication process, where we internally conduct reviews to ensure the claims are accurate, essentially reducing the likelihood that the state would reject those claims. And then once the claims are approved by the county, they're submitted to the state for reimbursement. And at any time, CCPs are made aware of what those denied claims or errors are, and they can correct and resubmit those claims, back to the county for payment. So we have, encountered that transition in the latter part of the fiscal year. And then finally, I think the other significant change that we've referenced in prior presentations is the transition from what we call cost-based reimbursement to a fee-for-service model. So formerly there was an opportunity for cost settlement in the way in which CCPs were reimbursed. Now, through the fee-for-service model, agencies are paid for the services that are delivered, and there isn't a cost settlement process at the end of that. So in the past, CCPs would submit, their invoices with units of service, and essentially there was a cost-based reimbursement model, and the agencies were paid based on their units of service multiplied by their rates or their actual costs, whichever was lower. And so this new change to fee-for-service means that they are paid based on services delivered and claims submitted. So that's another change in the current process. And then finally, I'll just mention, which we've shared as well, formerly with our agencies, we had negotiated rates by individual agencies. So every agency had their own set of rates that were negotiated by the county. With the transition to CalAIM payment reform, the county elected to develop a single set of rates with all providers by provider type. And so we have a single set of uniform rates that we have negotiated with all of our providers. So I just wanted to provide just some context for some of the changes so you're aware of the impact to the CCPs. But again, we have been providing a significant amount of technical assistance. We have our own county electronic health record team that meets on a very regular basis individually with all of the billers and staff in the agencies, and we're always available to provide that technical assistance, as well as have very open collaborative processes and opportunities in discussing options and strategies with our providers.
So I heard about 5 different things: the USCI transition, the training to the codes, to the CPT, NetSmart Avatar, CCP claims adjustments, some cost base going to fee for service, and also this negotiate rates. Let's go back. Negotiate rates makes it sound like it'd be easier, right? Because if everybody gets paid the same rates, that should not slow things down. Or am I misunderstanding how the system works?
Supervisor Lee, excuse the interruption. I am just mindful of the fact that I'm getting notes from the clerk that we have a hard stop at 5:30.
Okay.
Could I ask for your indulgence and perhaps maybe we get follow-up offline away from the meeting between your office and Mr. Rouse?
Sure.
But also then an off-agenda report as indicated.
Yeah, I just wanted to figure out what the bottleneck is, try if we can unclog this as fast as we can. And one second is, you mentioned the 15% advance, and that more could be increased. How much more can people ask for an additional advance? Because it looks like cash flow is the biggest issue.
Yeah, we didn't really set a percentage on top of the 15%. It's really something we could look at individually, agency by agency. And so in our current conversations with the providers, we're presenting some strategies in which we can then evaluate the percentage beyond the 15% that could be allocated as an additional advance to the agencies.
Yeah, given the urgency of that, I would say try to be more accommodating if we can. Thank you. That's all I have.
Thank you for your accommodation, Supervisor Lee. I know it's frustrating when we can't fully, but I'm betting Ms. Rosas is going to say on the record she's happy to meet with you at the earliest opportunity to sort these issues out. Yes, excuse me, not Ms. Rosas, Mr. Rao. Yes?
Yes.
There you go. All right, Ms. Rosas, now I'm in the right place at the right time. What would you like to share with us on Read the Valley Health Plan?
Thank you, Chair Simidian. Only that Covered California starts open enrollment November 1st, so we are working on a lot of outreach events in the communities, and as well as the Medi-Cal redetermination work, and our work also continues on stabilizing and optimizing EPIC, which went live on March 1st.
All right, thank you. And any other questions? None? Then custody health.
Good afternoon. Priscilla Luna for Dr. Day. I'll just share that in the custody setting, we have several program improvements that are underway. You have the report in front of you. Happy to answer any questions.
My only question is Mr. Williams, and forgive me for springing this on you, but I know we have some cause to be concerned about developments in custody health of late. Is that something that would benefit from an open and public hearing, a special hearing on just that subject? Or would you be more inclined to think that, given some of the litigation implications that we forego that opportunity for the moment?
I would advise that we forego that opportunity at the moment. It's already scheduled for an appropriate closed session associated with the consent
I will
decrees.
just sunshine that at some point, we kind of have to confront our challenges out here in an open and public space, and that time may be coming. So I will wait, listen, learn, and then reach a conclusion about what else we might need to tackle in a committee meeting setting. Thank you for the report, and thank you. EMS, how we doing? Ms.
Good
Lowther?
afternoon, Supervisor Lee and Supervisor Smitty, Jackie Lowther with EMS. You have our report. However, there is one thing I wanted to highlight and review, mainly about the contract ambulance performance. It was highlighted that the compliance report was not attached this time due to our online compliance utility not capturing all of the necessary data. So it was missing several data points from January to August. Currently, it is still missing about 3,800 data points, and not including the fire ambulance ambulances. So it'll take us probably till the end of October to capture that data. And so First SWAT is progressing on a pretty steady pace. But to compound that, we went live with our new computer-aided dispatch system. And so the new moving forward data will also be a little bit late. So that compliance is going to take us a little while to compound. The first responder compliance is coming through very well on their system. So as you can see, they're meeting their compliance, but GMR, AMR, Rural Metro, we're having a little bit of difficulty with.
Is there a date by which you feel optimistic we will be caught up and be able to say, I mean, today's the end of September, so I heard you say October, but at some point, do we say, you know what, we've got all the data entered correctly now, we've massaged all the data correctly now, and as of this date, we can look back over the last year and know what we have or haven't been seeing in the way of performance?
All of my sources from both GMR and my staff are telling me the end of October.
Okay.
So I'm hoping by the November 7th? Is it November 7th meeting? Except that report is due probably around October, so I can probably give you a verbal report on the November meeting as to where we're at.
Thank you. The November meeting I was referencing on the 7th is actually our board meeting. I can't remember, frankly, the committee date. So, but if we can ask you to see if you can move heaven and earth to have accurate numbers by November.
We'll certainly try.
That would be appreciated. All right. And then that takes us to the verbal report relating to federal health policy and budget landscape. I see Mr. Margolin. I see Mr. Campos. Is that why you've taken a seat here with us as well to be part of this conversation?
Yes, Mr. Chair, Chair Samiti and Vice Chair Lee, Deputy County Executive David Campos. Before I turn it over to Mr. Margolin, just want to note two things. One, on the state side, as you know, there's a report from our contract lobbyist from HBE in the report that was provided to the committee. And just note that there are hundreds of bills presently before the governor, and he has until October 14th to sign them. So we will keep you posted as we await that. And then on the federal front, there's a memo that just went out to the Board of Supervisors on the likely federal government shutdown. Congress has 3 days to pass a budget, which is highly unlikely, which is why we wanted to send that document. And with that, I will turn it over to Mr. Margolin.
It was artfully done. You teed up all that ugly news, and then you handed it right over to Mr. Margolin. So, Mr. Margolin, what should we know? Hang on, we're not hearing you yet, loud and clear.
Now we're on.
There we go.
So I'd like to start with just one brief comment related to the dense breast issue that you talked about earlier. Just a reminder to us all that there's legislation by Congresswoman DeLauro in Washington, the Find It Early Act, which would help facilitate the mission you set out for the county to make access to these diagnostic tests available to all women, regardless of income. The DeLauro bill would deny insurance plans the ability to charge anyone anything for such a test. And we're tracking that bill. It's not moving currently, but wanted just to flag that.
And if you have, before we get on to your wider report, if you have any information that you can share with us, I think you know our board took action to formally support, endorse the measure. And any ability to crystal ball the prospects for a bill like this in the current Congress?
Well, we've been in direct contact. My colleague Angie Melton in Washington has been talking to DeLauro's staff directly about the county's interest. And they're optimistic maybe long-term because they have strong bipartisan support. But in this current environment, because there are costs associated with the bill, they're not very optimistic short-term. Optimistic long-term, not optimistic short-term. It's going to take a different budget environment probably for the bill to move.
And, different folks have different notions of what short-term, long-term are. Does short-term mean not terribly optimistic this Congress, meaning 23, 24, or?
I would say 23, 24.
Okay. All right. Well, I'm guessing you know this, but please communicate through your colleagues if there's anything we can do here to be helpful, other than send our support. They should ask.
Yes, absolutely.
Okay, thank you.
We'll do that.
All right, now on to the
So
broader.
on the big
wait a
issue.
minute, one moment. I see Mr. Lee. No, all right. On to the broader report. Go right ahead.
The broader report, the issue that Mr. Campos teed up involving the likely government shutdown. It's Saturday midnight. That's our deadline. The prospects for a continuing resolution to keep the government operating are not zero, but there's so much dysfunction and miscalculation by the Republican leadership in the House that the odds are pretty slim that we'll avoid at least a short-term shutdown. There's one key difference about this crisis from past crises involving shutdowns. There's no single ask here, and no one in the leadership of the House and the Senate and the administration wants this shutdown. It's being totally driven by this narrow faction of 5, 10, 15 members. It varies by the day in the House Republican Conference, and we've never had a shutdown driven by such a narrow faction before. So what are Speaker McCarthy's prospects here for getting this shutdown avoided and the government funded? There are really three tracks that we're following here. The first is a Speaker McCarthy negotiation with his own caucus to get a unified Republican bill through. The second involves the U.S. Senate taking a leadership role, trying to sort of jam the House. And the third involves a rebellion by Republican moderates joining with their Democratic counterparts. And I'll talk very briefly about all three. On the McCarthy front, what he tried to do this week is move 4 individual appropriation bills through the House, which is what the Freedom Caucus wanted. He's talked about putting border security funding in all of this, and he's done everything he could to show movement along the lines of what the Freedom Caucus wants, with the budget numbers radically below the agreement that he made with President Biden just a few months back, breaking that deal but trying to placate the Freedom Caucus. He was hoping until maybe today that there'd be some break in the Freedom Caucus and he'd get, as a courtesy maybe at the very end, a few additional votes. There was a Republican conference a few hours ago, and the media interviewed members afterwards, and there are now 8 members of the Republican conference who said they don't care what the Speaker does, they're not voting for a continuing resolution. And there are several, to add to the problem, there are 3, 4, 5 Freedom Caucus members who say, well, we will vote for a CR. Yeah, we're open to that. But they want to vote for a CR with conditions that make it unsupportable by the U.S. Senate. So whether you're against a CR under any circumstances or for a negotiated deal, in both cases, it's a dead end for McCarthy, at least as of today.
So the next issue is the U.S. Senate trying to jam the House. They actually passed the other day on a 77-19 margin a CR that would keep the government functioning until November 17th. It included $6 billion for aid to Ukraine and $6 billion in disaster aid. And it gave the House another vehicle by which it could potentially break the impasse. The Speaker today said, on behalf of his conference, we're not taking up the Senate bill. It's dead on arrival. But I want to point out parenthetically, it's not totally dead on arrival because it's dead on arrival in its current form, with the Ukraine money in there and the other provisions. But what McCarthy could choose to do Friday or Saturday is he could choose to amend it and put in his border security money, some of which President Biden supports, and send something back to the Senate. So there could be a ping pong match, Senate to House, House to Senate, that could be a path forward. And the third dynamic here is the rebellion by 5, 10, 15 Republican moderates. And they have a couple of vehicles here by which they could rebel. One is a discharge petition, which could sort of move a CR to a bill to the floor that would then become a CR over the objections of the Speaker. On one level, McCarthy might actually welcome such a rebellion because it would allow for a CR to occur with his fingerprints not on it and his hands clean. It would be done by the rebels, not him. And it's a pretty aggressive act. There is a vehicle pre-positioned because of the debt limit fight. There is a discharge petition signed by 215, 214 House Democrats, and all it needs is 5 House Republicans to sign it, and in a matter of a few hours, and then you have a discharge petition ready to go, although there's a 7-day waiting period, so we'd still have a shutdown, but that's a possibility. And then there's also, and I won't go into detail because of time limitations and for other reasons, there's also a previous question motion that one could reject. It's a parliamentary device that could also involve rebelling against the Speaker and having these House moderates join with the Democratic members to get a CR through. But again, all of this is unlikely to work. There's a chance. We'll probably have a shutdown, likely a short one, maybe not, hard to know. The government is prepared for a shutdown, as the memo that Mr. Campos referenced outlines for you. There's been a lot of experience with shutdowns. The federal agencies are prepared. There's a category called essential workers that allows these agencies to keep certain functions operating because workers are considered essential. But nobody's paid, even the essential workers, and morale and coordination and performance is going to definitely suffer. There'll be a lot of chaos if there's a shutdown, no question about it. So that's the issue on the shutdown. I have, before taking any questions you might have, one last comment to make on the MCO tax issue, the other issue we've been tracking, and it really relates to your earlier discussion about revenue for the health department and your deficit. So there is in this MCO tax $32 billion in spending between now and 2019 that the state's going to have available, for the most part going to healthcare services. And there's dedicated money in there, $150 million a year, designated for public hospital systems such as Santa Clara. There are also several other categories of funding, emergency department funding, behavioral health funding, that depending upon what the governor does in next year's budget and how it's structured in the budget, Santa Clara could be eligible for. So an example of what this could mean, you talked about the quality incentive program, and Mr. Lorenz talked about the $160 million that we're currently capped at. If the MCO money was made available to us, and we don't know the methodologies yet, perhaps that 160 becomes 180 thanks to the MCO tax, or 190, and that pot is enhanced. We have behavioral health funding, we have emergency department funding. We don't know the methodologies yet, but just my final comment on this is we're going to have to be engaged in, and Mr. Campos and I have been talking about this on a regular basis. We're going to have to be engaged in an aggressive advocacy effort over the next several months through the budget cycle next year to ensure that public hospital systems get their fair share of the billions of dollars of new MCO money. And it is one path towards mitigating the budget shortfall you discussed previously. Just wanted to flag that, and happy to take questions.
If I could add just one comment about the MCO tax.
Please.
one of the concerns that we have had is in reference to that 150 million for public hospitals. Unfortunately, the current proposal has a provision that caps that dollar amount for the life of the tax, as opposed to letting it float as a percentage. And the practical impact of that, as the committee will well understand, is that, of course, over the life of the tax, the real value in terms of services that can be covered with that amount diminishes year after year. So that's a provision that's very concerning to us. It was something we did advocate against, something we continue to advocate around, but is a challenge for public hospitals because we've functionally, for that specific pot, been flatlined for the life of that tax as it's currently written.
No, important point.
Thank you. We're just about out of time, but Supervisor Lee, if you want to lean in with a question, this would be the time.
Yeah, so I think you lost me on the third option there, Ms. Margolin, regarding this deal of the folks in the 7-day waiting period. Is this something that those 5 Republicans has to identify themselves early on? This
Yes,
something
they would have to sign, there's a petition signed by every Democrat, those 5 Republicans tomorrow or Friday, and they have talked to the media about possibly doing this. They'd have to add their name. Once they add their name to the existing discharge petition, it has to sit for 7 days before you get the bill on the floor. And that's why we would have a shutdown.
And
but we might have a short shutdown if they did that.
Excuse me, gentlemen, just because now my curiosity's got the better of me, is the vehicle that they're talking about using the DeSaulnier bill that got a little press, gosh, a couple months ago?
It might be. I haven't heard it identified. It probably would be because that's the one that this discharge petition is linked to. I don't know whether they can substitute it for another bill or not. Probably not. It probably is that bill. Yes. That's likely.
If you happen to get notice and can send us notice just as a matter of curiosity,
I'll let you know.
not of immediate import to the county, obviously.
I'll let you
Excuse
know.
me, Supervisor Lee. Go right ahead. We have at least another 60 seconds by my watch.
My only real question is how's that going to affect us?
It will not affect us in the short term because the funding streams, the entitlement funding we receive through Medicaid and Medicare is not going to stop, and other funding streams in the short term are not going to be disrupted. So short term, it doesn't affect us dramatically. It affects our constituents who rely upon federal services. You're not going to get your phone calls answered. If you have a question about your Social Security allotment, there may be nobody at that desk to answer your phone. So constituents will experience confusion and delays in service. I don't believe, and I would defer to the other county staff here, that there's any immediate funding or program impact immediately.
VA hospitals, that's serving our community?
Not immediately because of the way the funding is structured. That's my understanding.
I would just note a off-agenda memo was distributed this afternoon to the board, providing a brief description of anticipated impacts associated with the shutdown. And yes, the short answer is not significant in the short term. Of course, if it extends, as time goes on, the impacts accumulate.
All right, then I think what I'm going to do is say thank you to all parties. I'm going to ask Supervisor Lee for a motion to receive
So
the
moved.
report on item 11 and all of its component parts. I will second. I don't believe there are any speakers on the item. The clerk is confirming that for me. She's going to call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Smidian.
Aye. And with that, all items have been addressed. And without objection, hearing none, the meeting is adjourned at 5:30 sharp. And you can tell me it's otherwise, but I'm going to say 5:30 sharp. Thank you very much.
Yes, okay, thanks, David. I'll be able to make it. This is these hard stops. It's a challenge. I've gotten kind of accustomed to.
Yeah, but it's a good thing because then it's.